Greetings to the world. Why is the one called Bruno Mars alongside Gang to the Zilla?
You know what I mean?
Standing at this liquor store, whiskey coming through my pores, feeling like I run this whole block. Lotto tickets cheap, yeah, that's why you can catch me here, trying to scratch my way up to the top. Cause my job got me going nowhere, so I ain't got a thing to lose. Take me to a place where I don't care. This is me and my liquor store blues. I'll take one shot for my pain, one drag for my sorrow. Get messed up today, I'll be okay tomorrow. One shot for my pain, one drag for my sorrow. Get messed up today, I'll be okay tomorrow. Me and my guitar tonight, singing to the city lights, trying to live with more than what I got. Cause 68 cents just ain't gon' pay the rent, so I'll be out until they call the cops. Cause my job got me going nowhere, so I ain't got a thing to lose. Take me to a place where I don't care. This is me and my liquor store blues. I'll take one shot for my pain, one drag for my sorrow. Get messed up today, I'll be okay tomorrow. One shot for my pain, one drag for my sorrow. Get messed up today, I'll be okay tomorrow.
Here comes Juna Gang, I'm flying high like Superman. I'm thinking that I run the whole block. I don't know if it's just because pineapple kush between my jaws has got me feeling like I'm on top. Feeling like I woulda stand up to the cops and stand up to the big guys, because the whole of them are sops. All the talk, them a talk, and employment no job. Enough ghetto youth cannot escape the trap.
Give me this one shot for my pain, one drag for my sorrow. Get messed up today, I'll be okay tomorrow. One shot for my pain, one drag for my sorrow. Get messed up today, I'll be okay tomorrow.
Now greetings to the world. Voice of the one called Bruno Mars alongside Gang to the Zilla, aka Damien Junior Gang Marley. Yes, sir. You best believe. Now, man. Yeah.
I could start dreaming, but it never ends. As long as you're gone, we may as well pretend I've been dreaming.
Okay.
Straight from the heart. You say it's easy, but who's to say that we'd be able to keep it this way? But it's
Let me know when you get
easier.
I think if you're like ready to go, then
Just do it.
yeah, go for it.
Okay.
Because it'll be recorded. You'll just introduce yourself on the mic first.
Okay.
And then give your shot.
Got it. Okay. I'll just be right back.
Thank you.
Low pressure.
Yeah, for sure. Okay. All right. Hello, everyone. Good morning. So my name is Sham Patel, and I'll be presenting on dynamic smile reanimation using free functional muscle transfer. And yeah, let's get started. So what's kind of the background for this? So facial paralysis, so this technique is used in patients with facial paralysis usually. And so if a patient has facial paralysis, they're going through psychosocial impact, or they might have some functional deficits, they might have aesthetic consequences, or they might have just something that they want to improve kind of with their facial tone. And so that's kind of what we're trying to address using the free facial muscle transfer. And there is not as much current evidence for these techniques. And so we're trying to show that, yes, we have some techniques that are used a lot, but there also needs to be backup, because what if someone doesn't have this type of muscle, or they don't have this type of nerve that we can use? And so it's very important that we have multiple backup options. So currently, something that's very well used is the gracilis muscle for this. That's kind of the gold standard currently. However, there's also lat dorsi, and we also have serratus anterior, but those are upcoming. And so we're just trying to show through this systematic review kind of how the current evidence is regarding these. So how do we go through these papers? First, we just went through a PubMed Embase database search. We had those, we had almost like 1,200 papers gathered from there. And then we narrowed it down using Covidence. So we used a double-blinded technique to basically bring it down to our 62 that we finally had in our final cohort. And we used search terms that were applicable to our project, which were the different types of flaps that we were looking at: gracilis, lat dorsi, serratus anterior, or facial reanimation, smile restoration, innervation, spontaneity. Those were kind of how we narrowed down which papers we were looking at. And then we had a small inclusion-exclusion criteria as well, making sure that we were only looking at primary clinical studies, and that they were also patients with long-standing facial paralysis instead of acute. We also had exclusive parameters as well, not including case reports, reviews, and editorials. Kind of those would give us a second point of a second-hand point of view instead of first-hand point of view, and so we just wanted to make sure on that. And we had a few outcomes on kind of like the key notes that we were looking at. The first one was commissure excursion. Second was facial symmetry, smile spontaneity, time to activation, and the complication and revision rates. Those were kind of the 5 criteria that we were looking at mainly. So first, we have the surgical technique already available, which is the gracilis free functional muscle transfer. And usually this just consists of, I kind of narrowed it down to 5 steps, but I know like the surgery itself is very complicated, way more than this. But first, it's just like the incision, getting to the muscle, picking out kind of the part that you want to harvest, and move into like the function, into our facial structure that's currently unhealthy. And you have like the flap insertion, and then using that to help gain the function again, and then suturing and closure at the end. And it's very similar to lat dorsi, but just a different muscle, different nerve there. And same thing for serratus anterior. I know I'm like, these graphics are not as accurate as an actual surgeon would do it, but this is just to kind of simplify it and kind of show us like the simple steps that are occurring. So our study overall had 62 papers, and out of that, 53 were gracilis, 6 were lat dorsi, and one was serratus. And I promise we did not only try to look for gracilis, But this is to prove our point that we have gracilis information very readily available. However, Lat, Dorsey, and Serratus are still upcoming, and we do need to look at them more. So again, evidence-based, gracilis is very high, Lat, Dorsey was moderate, and Serratus is very low. And then in terms of muscle bulk, gracilis is moderate, Lat, Dorsey is higher, and Serratus is lower. And donor morbidity as well, low, moderate, and then Serratus is non-reported actually, which again show that we don't have information about it. I think something to note here is the revision rate. So gracilis has a 42% revision rate. Lat, Dorsey has 33%, and Serratus, again, not reported because we only had one study, and they didn't even report the revision rate on there. So this is, again, to show that we do need to do more research into the Serratus flap and get more data on that. And this is one of the figures that kind of sums that up here. It's kind of showing the same thing. So I'm not sure if the pointer works, but we can see that the evidence volume for gracilis is the highest, and then muscle bulk potential is the highest for Lat, Dorsey. Serratus, it's the only figure that it would show more of is the ease of harvest and donor morbidity there. And then this was a very key map as well, showing that the SMILE commissure that are given by each of these flaps, they're also showing that gracilis is moderately high at 14.2. Lat, Dorsey, from the 6 that we got, these are averages, was a bit more than gracilis actually. And then Serratus anterior, again, the one study that was there did not report it. And the graph in B is just kind of showing us the gracilis points with the average in the middle and just how many studies were on either side. And for the innervation strategy and spontaneous SMILE, we had the innervation strategy that utilization, dual strategy is the most. So let me back forward a little bit. So like the 3 that we have discussed, gracilis, Lat, Dorsey, and Serratus anterior, these are the different muscles and nerves that we can use. This here is talking more about the actual technique. So we can do a dual technique, a CFNG only technique, or a masseteric technique. Dual would implicate using CFNG and the masseter. CFNG is only CFNG and masseteric is only masseteric. So dual is something that's used more prevalently. CFNG is, there was only 10 studies with that. Masseteric was 17 in that case. And then for spontaneous SMILE by innervation strategy, we have dual having almost 88.9 spontaneous SMILE. CFNG had 100% spontaneous SMILE. However, given that we only have 8 to show that, and then masseteric only had 33.3. And then here we're showing the time to first activation. So we can see that that CFNG took the most time, masseteric took the least time, and then dual took the middle time. And this is kind of an optimal balance because you're not only having the muscle, but you also have the nerve that has to activate. So that's probably why there's an average in between, but that was our guess on that. And in terms of the complication and revision rates for each flap type, gracilis, so again, these numbers you might see are not adding up to 62 because each study had a certain number of flaps that they were talking about. So out of all the 78 gracilis flaps that were talked about, 36 had a complication and 42 were revisions. Same thing for Lat, Dorsey, you have 83, but 50 were complications, 33 were revisions. And then we also had a reporting gap, and that's kind of what our main objective today is, to kind of show that we don't have as much information on other types of flaps as we should. So retrospective, we had 88%, 12% was prospective, and we didn't really have any RCT. And the commissurate excursion reported with was 32.3%. The facial symmetry reported was only 38.7, and spontaneity reported was only 14.5. So again, we don't have a common way to report these findings, and we should make it more of a norm to report these findings in all the studies. So in conclusion, Gracilis does remain the gold standard. Dual innervation achieves the most optimal balance of speed and spontaneity. As we saw, it was like the middle one that had it. And then innervation-specific trade-offs are well-defined. Lat dorsi and serratus anterior are very niche, and they need to be more studied. We only had one serratus anterior that we could find. And then lastly, there's a big evidence gap that still remains, and we need to standardize it. Because a lot of them did not report complications or didn't report revisions, things like that. So that's kind of what our conclusions were from this systematic review. And thank you. That was all. Yeah. Thank you. And any questions are welcome. I know I speeded through it, but please let me know.
We're getting our next presenter ready. But we should have a couple more. But Jacob Wagner is our next presenter.
Okay, I guess I'll get started now that everything's sorted. Okay. So there are some occupational risks in otolaryngology that, oh, hold on. Sorry, I didn't realize we weren't on the next slide yet. Okay, so this project started because there were a number of different surgeons at my school at Rocky Vista University that mentioned that they had chronic back pain or neck pain, etc. And I thought it would be a good idea to gather all of the current data to then help younger surgeons, help trainees, even more established surgeons that can still correct their posture. Oh, I haven't clicked forward yet. Okay. To experience or to see what changes in their posture or what changes in their working environment can help them increase their working lifetime and their longevity. So this is just a narrative review. I'm still working on the literature review. But basically, search terms included otolaryngologist, of course, musculoskeletal disorder, ergonomics, endoscope, exoscope, things like that. All of it included peer-reviewed articles from English studies between 2010 to current. And there were 60 that ultimately, or around 60 that were ultimately synthesized. There were quite a few in the beginning, I think well over 1,000, and we ended up narrowing it down to 60. So the unique characteristics of otolaryngology, the things that we do most, or well, hopefully me as well in the future, that you all do most, is prolonged static posture. So you'll be at these scopes for long periods of time and you won't be moving, and you'll be locked in on what you're doing to, of course, have the best outcomes. And once you're locked in and you're in that Zen type state, that focus, you don't want to regularly be taking breaks and stretching, or you just kind of forget about it, maybe, things like that. So a lot of different articles and things found that that fixed posture is one of the most detrimental aspects, especially on our necks. So when you're looking through the scopes, you're forced at a decreased angle, of course, to an extent. And so one of the main, I guess we'll touch on how to approach that later, but that's one of the worst parts about looking through scopes regularly. Additionally, the confined fields make it so that confined fields make it so that you can't move your arms as freely, or you are just in, just having a more narrow space. You have to constantly use the same muscles rather than relying on some of those bigger muscles that can typically take strain in normal everyday activities. Here's a heat map of the most common locations. Basically, the most common area is the neck, like I was just saying with the microscopes. And then the shoulders, especially in specific surgeries such as endoscopic sinus surgery, or in laryngology where you're working without adequate arm support, and so you're using, again, those small rotator muscles, or some of them are smaller, and you're just constantly aggravating them and putting a lot of strain on muscles that shouldn't or typically don't have that kind of strain. And I just want to make note of that last slide. It said 47 to 97, I believe. Yeah, 47 to 97% of otolaryngologists report work-related musculoskeletal disorders during their careers. And of course, that's a wide range because different studies found a variety of different results, but somewhere in that range. So if you just take, the rough average, if 70%, so 7 out of 10 otolaryngologists end up experiencing musculoskeletal disorders that are affecting or ending their careers, then that's quite significant. And there's also a huge gap in training where even residents, 90% of residents in some studies were found to have musculoskeletal related complaints and had to take off time and things like that. So here's just a quick figure. This is a pretty commonly cited, pretty well-known study where 15% flexion increases the weight on your cervical spine by 27 pounds, 30% flexion by 40 pounds, and so on, as you can see on that chart. And let's dive into how to approach these. So some of the technological solutions that we have now are heads-up displays or 3D exoscopes, where you can actually have your head in a totally neutral position and have the 3D imaging. This isn't available for every subspecialty or every type of surgery, but I'm confident will be in the near future. They're constantly advancing this technology, and it's growing quite quickly. Also, adjustable microscopes and loops, like the ergo loops, are significant in terms of reducing that neck strain. especially where that's the most common complaint, that will be the most beneficial to quickly address. And then using voice and foot pedal controls are of course beneficial as well, to share the load on different parts of your body. I mentioned this very briefly earlier, but taking those micro breaks every 20 to 40 minutes just to stretch your neck, to move, to get out of that static posture and get yourself a little bit more limber every so often is beneficial, just to increase blood flow, to reduce that strain on those muscles, even if for a brief period of 30 to 60 seconds makes a large difference over time. And then practicing alternating hands. We're always told as medical students to become ambidextrous, right? And to constantly use both hands for different things, especially if we're interested in surgical specialties. And that doesn't stop as a student. That should continue on throughout our careers. Some of the things that are most beneficial in also improving those rates of musculoskeletal disorders is targeted resistance training and stretching programs. Even cardiovascular fitness have been shown to decrease the rate of disorders. I'm getting low on time, so I'm moving along a little faster. And then environmental optimization is arguably the most important, just because it's so easy to not get our stool heights or our table heights to the exact position that we need them to be. So if you can do that before starting your operation, that is huge, especially over our careers of, at least 20, 30 years. That compound is significant. Even adjusting lighting was a big deal. And then educational interventions, especially starting in residency, is one of the best ways that is determined to help us early in our careers to adjust the way that we're practicing throughout the rest of our career and ensure that we are actually taught that this is something that we should think about, that this is significant, that we need to learn to position ourselves correctly. Okay, I think I'm pretty limited on time at this point, but any questions? Yeah.
Did your review mostly look at general laryngologists, or did you look at subspecialty?
Mostly general, but there were a few different articles that included like pretty specific, like Irish audiologists and things like that, but yeah, mostly general. Yeah.
Do you see anything about the vision? I feel like with the amount of time we spend wearing loupes and in microscopes and things like that, did anybody talk about vision changes?
Not that I saw. Yeah.
Not technically ergonomics, but it's position.
Mm-hmm. Maybe we need to present this to our colleagues next door. Okay, any other questions? Okay, thank you.
Our next presenter is Haley, and she is, start. Can I bring my laptop and see my? Oh, yeah. And then how do we advance? Okay. Green, okay. Hi, everyone. My name is Haley Harbert. I am from VCOM, Virginia, and I'm going to be presenting on my project, The Current Landscape of Otolaryngology, Care in Malawi, and it is a scoping review. So some background on our project. It is well known, and otolaryngology disability is well characterized in sub-Saharan Africa. However, we wanted to look at the implications for Malawi specifically, and there was limited research or data put together for Malawi specifically. We know that there's over 40 million years lived with disability annually due to otolaryngologic problems, and this is more burdened by the fact that there are fewer than one ENT surgeon per million people in many countries in sub-Saharan Africa, and these gaps with late disease presentation and cause increased morbidity and significant economic burden to the healthcare system. So our objective, again, was to characterize this specifically to Malawi to help target interventions, and identify specific gaps that Malawi might have differently than other regions in sub-Saharan Africa. We used the PRISMA scoping review, and we looked at studies between 2015 and 2025, and we came out with 54 studies. Half of them ended up being primary or from Malawi itself, and then about half were secondary, which means more they were generalizable to sub-Saharan Africa and maybe mentioned Malawi once or twice. So we came out with 5 themes. Our first theme, we wanted to look at the epidemiology. What was the problem? We found that the most striking was about 5 to 6% of children aged 4 to 6 suffered from hearing loss, and about 50% of those were from preventative causes like otitis media and cerumen impaction, which again shows that that might be our target. There were also things like we found how they perform in school and how this kind of transfers to the rest of their life, and even mention of neurocognitive decline, like things like dementia when they grow up. Our next theme was infrastructure and service delivery. So how is the care delivered currently? And we found that there are more rural areas and then urban areas. The urban healthcare systems were driven by government funding. However, even when there was referrals made to the more urban concentrated centers, families from rural areas could really not uptake the referral, and it was like a 75% loss to follow-up among those patients. And other things like audiology care and speech pathology were essentially non-existent. Our next theme was, how do people seek care? So one of the most, I think, striking that I found was that patients who would try to go to the referral in the more urban areas were traveling about 1 to 2 hours, and that's by foot or bicycle. So it kind of gave us some insight on, even if the care is there, that they might not be able to access this care. And also the literacy of the caregiver greatly affected whether they were able to uptake with that referral. And so there's a pilot study, at least one, that looked at how can we improve the healthcare literacy or just literacy in general of the caregivers, and one was with an informational pack. They tried counseling with a community healthcare worker or an expert mother, and then things like text message reminders, and they did see an uptake in the referral when you added a little bit of education. So the workforce capacity and training, I know this is pretty busy. There was a couple different things we wanted to look at. So for your training of ENT physicians, there is one ENT training program, and it's an 18-month clinical officer course, which covers the basics of ENT. However, there's no audiology or speech pathology programs in the region. And there's also one fellowship that has 12 fellows, and that are trained by Western surgeons. However, they often found that some of these skills were non-transferable, so our Western surgeons could teach, but there's a whole different resources and technology that might not be available there that our surgeons are used to using. And other things like a survey of medical students that showed interest in surgery and internal medicine, but very little interest in ENT care, which is one of the main burdens of the region. And then things like task shifting to community healthcare workers or nurses, even teachers, have them doing hearing screening, was looked at for an increase the workforce. Our next was technology and multi-level solutions. I thought this was one of the most interesting themes that we looked at, and it looked at how do cochlear implants cost compared to a lifetime of deaf education, and they did find that the deaf education was more cost-effective than even your lower cost cochlear implants. It also looked at low-cost hearing aids, which were donated from a European company, and it showed comparable performance to other high-cost options. Also, solar-powered otoscopes. One of the things we read was when your otoscope dies and there's no light bulb, how do we charge it? And that was often an issue, which things we probably wouldn't even think about. And then things like AI to help. This one was from Kenya, however, it was sending pictures of otoscopy into AI and see if it would diagnose correctly, and there was about a 79% diagnostic concordance between primary care physicians and the AI. However, AI did not perform better than ENT specialist. So I think what we gathered from all of this information was the importance of targeting our efforts when we travel somewhere to help out a region, that we look at what they have and not necessarily put what we are used to teaching in our resources, but look at how their system works and specific things like traveling an hour or two to a doctor, not having electricity to charge your instruments, things that we might not even think of. Again, this is not only assessing the cost of your materials, like your equipment, your otoscopes, hearing aids, but looking at the indirect costs. How are people getting there? We hand out the referral, but how do they even get to that referral, I think? And then things like task shifting, how appropriate is that? And is there a place for that in care? And I would like to thank the Maggie Mullally Foundation and Dr. Robbins for all their support. Any questions?
All right, good morning, everyone. My name is Kalen Sorensen. I am a third-year medical student at Rocky Vista University College of Osteopathic Medicine in southern Utah. I'm going to be speaking to you all today about a study that I was fortunate enough to be able to do with the University of Buffalo residents about the nationwide adherence to Bell's palsy clinical practice guidelines set forth by the American Academy of Otolaryngology. So we did a 20-year retrospective analysis using EMR database that was nationwide. So a quick refresher on Bell's palsy. Most of the attendings have probably seen this multiple times a year, but it affects about 20 to 30 people per 100,000 worldwide. It's commonly accepted as an idiopathic cause, but can also be found to be caused by HSV and rarely Lyme disease as well. Most of the time, patients are able to recover from it spontaneously. 85% are able to do that within 3 weeks. However, approximately 30% of those patients can experience incomplete recovery as well. So with these patients, treatment, as soon as we're able to provide that diagnosis for them, is critical for their quick recovery. So background, the American Academy of Otolaryngology in 2013 published their clinical practice guidelines to be able to help guide providers, whether they're ENT, primary care, whoever might happen to come across patients with Bell's palsy symptoms, know what to be able to do as far as diagnosis and then guiding towards treatment as well. Previous studies that have been done on the guidelines were done at like an institution level. This is the first study of its kind to be able to do a nationwide, worldwide analysis. So the AEO said their purpose for it ultimately was to improve accuracy of the diagnosis, improve the quality of care, and outcomes for the patients with Bell's palsy, as well as decrease harmful variations in evaluation and management of Bell's palsy. So it's, like I said, it's intended for all clinicians in any settings and is also meant to be able to target both children and adults. So the guidelines that they set forth, they strongly recommend that when you have a patient come in presenting with Bell's palsy symptoms, that you provide oral steroids within the first 72 hours for patients that are 16 and older, that you do not just prescribe antiviral therapy alone. You can still use them with the steroids, just not by themselves. Recommendations in general, they don't recommend routine lab testing, such as for the HSV, for VZV, things of that sort. They don't recommend doing any diagnostic imaging for patients with new onset Bell's palsy, and they don't recommend that you do any electrodiagnostic testing with patients with incomplete paralysis either. And then optional oral antiviral therapy can be used with the steroids, like I mentioned, within those first 72 hours. And when the patient presents with complete facial paralysis, then electrodiagnostic testing might be worth considering as well. And then, I didn't put this on the slide, but obviously with anyone coming in with Bell's palsy symptoms, you always want to look for signs and symptoms of like trauma, cancers, anything else that could potentially cause it that is an outlying issue other than idiopathic or infectious. So the methods we use the TriNet X EMR database. It's a nationwide database, and we use the date range from 2004 to 2024. Again, the guidelines were set in 2013, so we compared the before and after effects of using these guidelines. So the data that we collected was the steroid use within 72 hours, the antiviral use, whether it was acyclovir or valcyclovir, the use of imaging, and then if there was serologic testing for VZV as well as Borrelia burgdorferi, and compared before and after those guidelines were set. Statistical analysis, I won't bore you with the specific details, but a chi-square was used, and then we specifically adjusted for combination therapy versus antivirals alone versus steroids alone. In our results, we had over 250,000 patients, almost 24,000 of them before the guidelines, and then the rest after. The demographics were mostly female, and then mostly white patients as well. We did have a good chunk in the race category, 15%, that had no race data, but overall a pretty good distribution across the board. So here are our results. at least on my end, the colors don't show up very well, but you can see that the serologies for Lyme, HSV, VCV all increased despite the guidelines being posted, as well as imaging, electrodiagnostics, and basic labs. So the things that we put the guidelines out for, or that the AAO put the guidelines out for, they still ended up being used routinely. However, the use of antivirals and corticosteroids also made a huge jump. So the good things that we wanted to happen out of these guidelines did occur. However, some of the routine things that shouldn't be happening continue to progress in routine diagnostics as well. So why this matters, doing all of these unnecessary imaging, diagnostics, serology can put an unnecessary cost and burden on the healthcare system itself, as well as the patients, and having them come in and do some testing that is not entirely needed. Market scan database that we mentioned within the study showed that from 2013 to 2020, 66,000 patients in this study, that by specialty, EM was really good at following the guidelines. However, the least followed specialty was actually ENT. So it is important that these guidelines were set out by the AAO, and yet ENTs are the lowest adhering, at least according to this study. So still something that can be improved on, at least in our field. And then one single institution study that we mentioned with 903 patients showed that even though the patients in their study had 89% use of steroids, there were about 20% of patients that weren't prescribed the complete 10-day course that is recommended by the AAO. So lots of room for improvement. Limitations of our study is that based off of the ICD-10 codes that we use, there's a potential for misclassification based off of the provider's own inability to be able to recognize the disease, or possibly patients just being grouped in when they shouldn't be. The approximate timing of steroid administration, we weren't able to get a lot of the specifics with that. We had to kind of base it off of the prescription or administration records according to the diagnosis date. And also with this EMR, the onset of symptoms might not be exactly precise. And then the dosage duration and adherence to steroids and antivirals were also limited. So, and then clinical details that a lot of providers specifically care about in their own field, whether it's the severity, comorbidities that the patients are dealing with, or they might come in with symptoms that don't entirely fit what we normally see with Bell's palsy, also matters on a clinical setting, but with this study we weren't able to evaluate every single individual situation. Ultimately, everything that we found is good info to be able to use, and going forward it'll be able to help guide treatments and diagnostics for patient. But ultimately, we do have to remember, with it being an EMR database, even though it's a nationwide database, it can't be generalized to the entire population or every single practice setting. So another thing to keep in mind. So conclusion from this study was that the use of steroids and combination therapy did significantly increase, as we were hoping with the publication of the guidelines. But with that, the unnecessary diagnostic serologies, imaging procedures also increased. So something that can definitely be improved going into the future. So future efforts as we go forward would be to improve the treatment quality and diagnostic standards for those patients that present with Bell's palsy. Thank you, and any questions?
Good morning. In the interest of staying on time, we're going to introduce our first lecturer this morning for the laryngology section. Thanks to everybody for being here bright and early. So our first lecturer really needs no introduction. Dr. Libby Smith has served many roles in our college and has really been a trailblazer for osteopathic laryngology and otolaryngology in general. She's been the first of many things, so that have really kind of allowed the other osteopathic laryngologists that are in this room and that are going to be speaking today to really kind of pave the way for us. So we give Libby lots of props. But anyway, she's a full professor at the University of Pittsburgh, and she's spent her career there. She trained in Dayton, and she did her fellowship with Bob Sadeloff in Philadelphia. So without further ado, Libby Smith.
All right, thanks, Lindsay. So I was tasked, first of all, thanks for inviting me to come talk today about maybe not a topic I've ever talked about, so it's something different. So I'm going to talk about basically infectious laryngitis, and we're going to see some icky pictures. They're going to make you want to drink your water because it just looks like that. And we're going to go through like a litany of different things. So crusts happen, and this is the sticky situation in the larynx. I have no disclosures. So we're going to talk about 5 different patients, each having a different infectious etiology for their laryngitis. We're going to go through the history, which is absolutely critical on these patients, as well as the flexible laryngoscopy or endoscopy of the larynx, and then discuss treatments, right? And not only just definitive treatments, but the concept of trial treatments, because sometimes you're not 100% sure, and then the concept of reevaluating afterwards to make sure you had the gains you wanted to. So let's start with a 59-year-old guy. He came to me referred from an outside otolaryngologist. He'd been hoarse for 6 months. This is his larynx. Which again, everyone just take a sip of water. Nothing makes his voice worse, but interestingly, drinking water makes his voice better. He's not the healthiest guy. He's had pneumonia twice in the last year and required antibiotics. It's a pretty complex medical history, and so this is all of that part of history taking, right? So he has Crohn's disease with a partial colectomy, obstructive sleep apnea with CPAP use, and hypertension. He is a longtime smoker, drinks lots and lots of caffeine and basically no water. He owns a bar, so he drinks a fair amount of alcohol. So you see this, and what do you think? Like just, right? It just looks dry. So, but you have to think about, you can't just automatically go there. You always have to think about what are the red flags, right? Because white, icky stuff on vocal folds, we always have to have tucked away in the back of our head cancer, right? Which is what the referring doctor did, because he even got a CT scan, which didn't show anything, not surprisingly. So red flags for this guy, he's got a long tobacco use, hoarseness for more than a month. If you're over the age of 40 and hoarse for more than a month, that's cancer till proven otherwise, you gotta look, right? Infectious, sure. I mean, he's not the healthiest guy. He's had a bunch of antibiotics. His issue, though, is sicca, right? He's had a colectomy. He's on CPAP, he drinks a lot of caffeine and no water. Those are kind of his hits to the system. And you don't see any real masses, right? Mucosal masses, it's all just gunk sitting on top of the vocal folds. So when you look at this gunk on the vocal folds, very technical, you see that it will shift and grab. So as they adduct the vocal folds, it will kind of like attach to both sides and then pull apart. It's like this like spider web idea along both vocal folds. There's not associated erythema. Dryness matters because the vocal folds don't like to be dehydrated. You then lose this thin mucus layer along the vocal folds, making them less pliable, more stiff, and more increased risk to injury. So there's lots of things that can make you dry. Obviously, I see in my practice, no one drinks water. I'm actually one of those people, but no one drinks water and everyone drinks too much caffeine. Like so many energy drinks and stuff like that, pots of coffee. CPAP use. Pittsburgh is known for its size among many things, and so there's lots and lots of CPAP use. Everyone's going to be dry even if you have humidification. You just have to say that's part of it, right? Just drink a bunch of water when you wake up. Medications are a big one also, and with the polypharmacy going on with all of our patients, right? I mean, who isn't on an antidepressant, something for their ADD, Lasix, antihistamines, their inhalers, you know, in addition to the medical issues that got them to be on all those medications, diabetes, GI issues, cardiac issues, renal issues, right? So there's lots of things that can dry you out. So what's the treatment? Oh, doesn't this look so nice? So hydrate, right? So it's sometimes just as simple as you need to drink more water and less caffeine. But you can add personal steamers, which you can get online or in the grocery store. Saline nebulized treatments are phenomenal. I'll make a little side note, especially for your Sjogren's patients, and just put saline in it, and they do great. Gum and hard candies can incite more saliva, so you can feel like you're a little bit more moist in there. Avoid basically smoking as possible, and then working with the PCP on the polypharmacy issue. I mean, I never take people off of their antidepressants. That seems like a really bad idea, but it's a matter of having a conversation when you see lots and lots of med listing. Maybe this is an opportunity to work back with the PCP and see if there's anything you can come off of. All right, let's shift gears here. This is nope, I'm not gonna shift gears. I've got here, but I don't have you guys. I'm still plugged in. Do you want me to come off and go on yours?
Over this way.
But that still didn't work. Is that not the right one? Okay, awesome, thank you. Okay, all right, well, y'all didn't want to see this picture, obviously. This one is more crust on the vocal folds, 35-year-old man. Just look at the picture. This looks very different than the last one, right? This one looks kind of more goopy, right? Again, super technical. So this gentleman has had hoarseness for 3 weeks, sore throat, low-grade fever, productive cough, throat clearing. His voice only gets better when he hawks up this stuff. He was seen by his PCP, given steroid. His sore throat got better, but he's still been hoarse. He's otherwise a healthy guy. He actually is hydrated and doesn't smoke. So red flags for him, there really aren't any, right? I mean, we're not worried about cancer, and he's actually well hydrated. He's just got all this like wet, goopy white stuff all over his larynx, right? Especially that river of it flowing along the posterior aspect. So we're thinking infectious, right? He's had a sore throat, that's a big tip-off. So he actually has suppurative laryngitis. Now, it was kudos to the PCP for not giving him antibiotics. That's actually not the norm, and this PCP did the right thing, not giving antibiotics. Most of the time it's viral, but if you have persistent laryngitis for more than 2 weeks associated with all those cold symptoms, then it's probably suppurative, and maybe it was suppurative on top of the initial viral. So strep, group A strep, even though strep pneumo is more common, but group A strep is one of the main issues with suppurative laryngitis, as well as Staph aureus, including MRSA. So even though most laryngitis is viral, it's estimated about 60% of the time people receive antibiotics from their PCP, right? Which is not helping with the ability for antibiotics to do what they need to do. Only about 10% of these patients actually have group A hemolytic strep. So the treatments are what we know, right? And when you need to cover for MRSA, you've got a different line of medication. So if you look at these, my go-to is doxycycline because it sits on both, right? And most people don't give doxycycline. So patients are usually a little bit more naive to it, which is good because then you might actually be able to kill whatever's going on in there. So the treatment is relative voice rest because if your voice isn't working, don't push it. You can't make it work at that point. You gotta get rid of all this gunk, right? Hydration, and then just general supportive care, as well as, you know, your antibiotic treatment. So this guy underwent doxycycline, and then as soon as he came off of it, it came back, his hoarseness, and you'd see him back in the office, it looked just the same. And so guess what? I'd give it again, right? And maybe I'd give it instead of 2 weeks, I now gave him like 3 weeks. And then weird, he'd come back and it'd be better, and then it'd get worse again. So I was like, this isn't working, right? So I ended up doing an in-office biopsy, because fortunately we're able to do that, and worked with our infectious disease folks and got cultures and sensitivities, and it turns out he had MRSA, right? So in collaboration with the infectious disease team, he's now finishing up his 2nd or 3rd month of doxycycline, okay? Hopefully that will eradicate it. All right, let's shift gears. So this is a 59-year-old woman who's been hoarse for a month. She otherwise was healthy. She didn't have any cold symptoms. She was seen by your PCP. Guess what she was given? Antibiotics and steroids. She has a medical history. I'll tell you, it's actually not germane to what's going on with her. And she's hydrated and doesn't smoke. So what do you see with this one, right? The big thing is you've got these bilateral discrete lesions, and they're in a very specific spot. All right, so they're mid-membranous, mid-vocal fold, and they're kind of along the superior surface, which is a weird thing to have, right? So this is very specific. Not worried about cancer, because cancer doesn't happen like that. I'll tell you that I see these sort of seasonally, not necessarily during a certain season, but if one patient comes in, I'm going to expect another 3 or 4 to come in probably in the next month or so. They're not sicca. So look at this picture. Hopefully you can appreciate it. You've got these like kind of yellow ulcers on both vocal folds, okay? And so guess what that is? Idiopathic ulcerative laryngitis. It's actually very uncommon. It's suspected to be viral. We don't biopsy these to figure out what it is, because they're self-resolving eventually, and we'll get into that. They always happen in the same spot. And why? I have absolutely no idea. But it's always in the same spot. Early on, you'll see the ulcers like the lower picture, and then as it starts to heal, you'll see more like the upper picture, where you'll see these like eschar with raised edges. And then in the late phase, you can actually see scar, and that's what we're always worried about. So what do we do for these folks? We have no idea, so we throw the kitchen sink at it, right? So voice rest, if your voice, again, isn't working, don't make it, don't push it. Hydration, sure, give them a steroid, why not? Antivirals, I'll give antivirals if I get these folks early on and they're in that like acute ulcerative phase, because again, it might help speed up the process of healing. A lot of otolaryngologists will give antibiotics. I tend not to, but you could. Again, you're just throwing anything at it. Eventually, once you start throwing all these steroids and antibiotics at them, you're probably going to cause a fungal infection, so they might need an antifungal at some point. And then a lot of people, because we're ENTs, we put everyone on antacid medicines that may or may not have a big impact with this. So eventually, these almost always resolve on their own, but it can take like 3 months, right? So there's a ton of hand-holding. And I'll usually see these folks back every, like, maybe 2 weeks up front, and then maybe a month down the line and another month down the line, just so that they know that someone's still keeping an eye on them. If it doesn't heal, I mean, at some point, do you have to biopsy? I've never had to do that, but that would be something you could always consider. But you have to be patient up front. The risk is vocal fold stiffness, so if I do see that, I'll actually do steroid injections. And again, I have the luxury of being able to do that in the office, so it's not a huge outlay for the patient, but you can actually do superficial steroid injections right into the area that's scarring, and that may or may not help again. And fortunately, these rarely recur. All right, so this is an interesting gentleman, 61-year-old male. He actually came to me for ulcerative laryngitis, right? We just saw that. There he's got it on his left vocal fold. He was a unilateral guy, not a bilateral guy. And he had sicca, right? Because he's on a bunch of psych meds and steroid inhalers for his bad COPD and his really debilitating psychiatric illnesses. So he also is a longtime smoker. He was awesome because he's so petrified of getting cancer that he's been the most compliant with hydration. He's actually cut down on his smoking just to treat his sicca. So he comes in and sees me every 6 months because he's worried about having cancer, even though I'm like, that's not yes, you're at risk because of smoking, so I guess we'll keep looking. So he came in 2 appointments ago, and this was his exam. And so what's different about this, right? It's a little bit dark, but I hope you can appreciate there's kind of like all these white dots everywhere, okay? And there's kind of a white film sitting on the vocal folds, right? And so as I'm talking to him before I even saw the larynx, it was like, so what's been going on? He's like, yeah, you know, my voice got worse. Did anything happen around that time? Yeah, actually I sprained my ankle and they gave me a steroid for it, okay? And that's where the history comes in, because that's got to go ding, 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 ding. Okay, I'm thinking now maybe fungal, okay? Still staying hydrated, et cetera. So cancer less likely, because cancer doesn't show up as like little white dots everywhere, right? And he's got baseline Sicca. So he has fungal laryngitis, right? I remember as a resident, I was always taught, well, this really just happens in immunocompromised patients, but I see it a lot in immunocompetent patients in the setting of inhalers and uncontrolled diabetes and antibiotics and steroids and stuff like that. So you get this perfect storm. You'll see these hyperkeratotic lesions that with sometimes a base of surrounding erythema, and you'll just see all these white dots, okay? If you see those white dots, that's a surefire, you know what's going on, but sometimes you'll just see a little bit of erythema and maybe a couple white dots, so you have to really be looking. We talked about that perfect storm of what leads to the change in the microbacterial milieu so that the candida basically can take over. The treatment for this is usually not nystatin, especially if it's on the vocal folds, because when you drink stuff's not supposed to sit and bathe on your vocal folds, so your treatment's fluconazole. And you need at least a 2-week course, and oftentimes repeated. So my usual is 2 weeks, I see them back at 3. If they need another round, we do another round, right? Unfortunately, fluconazole, which is the only med we have to do this, interacts with so many things, right? So for this guy, I had to work with his PCP for his anti-anxiety, anti-depression medications, right? We had to play around with his meds so that he could actually take the fluconazole safely. All right, last but not least, now we've got a 72-year-old woman. So she's got these white plaques also, right? And they look kind of wet, right? So you're thinking, oh, well, could this be suppurative? Well, suppurative doesn't come in clumps like that, right? It's kind of like that river that we saw on that other person. It could be fungal, and it turns out for this lady, she has long-standing dysphonia. She has horrible lungs, so she's on 2 steroid inhalers. She quit smoking years ago, but the damage has been done. And so she gets recurrent fungal laryngitis all the time. She comes in, I don't even see her back in between her, at that 3-week appointment, she'll just let me know if she needs another round. I usually order 2 rounds of fluconazole every time she comes in, because that's usually what she needs. So this is her situation, right? But you have to remember, she still was a long-time smoker in the past. So when you have them come back and see you, if the white stuff isn't gone after multiple courses, you have to think, maybe it's not all fungal, right? So you still have to keep in the back of your head, there is a cancer risk here, right? She has this tobacco history, and so at some point you're going to need a biopsy. So every year or so, just so I can keep track of what's going on, we take biopsies. So the first ones were from 2022, I think it was, when she was safe enough to go, her lungs were strong enough to go to the operating room, and basically she had mild to moderate dysplasia with fungal elements throughout, right? And then this last bottom one is just from January of this year, and again, the fluconazole wasn't clearing everything. This is after she had received 4 weeks of fluconazole, the picture on the bottom left. It's like, well, we got to do something else, right? So then we did some biopsies, and now she's actually worsened her dysplasia up to moderate to severe. So she's in a more high-risk category. Now we can get in a whole other talk about issues with in-office biopsies and the accuracy thereof, but in general, it's worsening. So really the take-home points are lots of things can cause white stuff in the larynx that's infectious. The history and the exam drive everything, and the history is really important. Treatment, algorithms are great, but that reevaluation is really key. right? You need to make sure that you impacted the effect that you wanted to do. And then keep an open mind, like that last lady. Maybe it's not fungal. Maybe we need to look into more of a dysplasia issue. So, thank you very much.
All right, thanks, Dr. Smith. So up next, we have Dr. Sandra Stinnett, who is also currently at the University of Pittsburgh, and she also works at the VA Medical Center in Pittsburgh. She did her otolaryngology training at the University of Miami and her laryngology fellowship at Johns Hopkins. She is just an awesome human that we're very fortunate to have today. She has lots of energy. She's enthusiastic about caring for her community, especially underserved populations, and advocacy for women in surgery. So if you don't yet follow her on Instagram, you absolutely should for the entertainment value and educational opportunities. So, Dr. Stinnett.
Thank you, Dr. Madden. Thank you, guys. This is awesome meeting. I'm grateful for the opportunity to share some thoughts about hormones in the human voice, where endocrinology meets the larynx. I don't see, oh, this is the clicker. Just the green button? Got it. Okay, I have no disclosures. So we'll go through a few clinical vignettes. We'll talk about the 38-year-old female singer, sudden loss of high range mid-cycle, the 55-year-old executive that her voice doesn't carry anymore, and then the 19-year-old male who had rapid pitch drop and instability. And these are all interesting because they all present probably with the similar complaints, very benign presenting exam, but we need to acknowledge that same organ, different problems, and why. So voice complaints in our patient population, they're just not purely structural. Oftentimes we're expecting one thing when the patient comes in and we think that we know exactly what the issue is, but we need to really dig deeper and understand that there are other components that may be contributing to their dysphonia. And one of those things is hormonal shifts, and that truly is an under-recognized driver of dysphonia in our patient population. And I must admit, in patients that aren't professional voice users and don't notice the subtle differences in their voice where they're reaching a ceiling in their pitch, or their passaggio is a little bit off, I may not be more investigating hormonal shifts, but I think it's something that we really need to look at, especially in our menopausal population and just aging patient population. So it impacts singers, professional voice users, menopause, aging population, and even now with our gender-affirming care. And it's important because oftentimes what we think is one thing, a patient presents with atrophy or minimal atrophy and we do a vocal fold injection, that may not be the right solution, and we may need to be considering other influences such as menopause that may be influencing the voice. This is a picture of the Pittsburgh Opera. Just an aside, one of the pioneers in hormone voice is Dr. Jean Abitbol from Paris, and he has a book out that talks about larynx and hormonal influence, and his wife is a gynecologist, so they look at the hormonal impacts of the cervix and the larynx, and histologically their changes hormonally are very, very similar. And he talks about how opera singers back in the day, they would have something wrong with their aria, and the vocal coach would say, hey, okay, if you're around your premenstrual cycle, maybe you take a week off. So they would put in these open grace periods for these singers because whenever they had these hormonal changes, according to their menstrual cycle, it would affect and impact their performance. So receptors that we suspect that may be present, estrogen, progesterone, androgen, and sites anywhere between the vocal folds, vocal ligament, epithelium, and the laryngeal muscles. So we need to take into consideration that the viscoelastic properties are important. There may be anatomical variations, but also hormone responsiveness is another key. And it changes our thoughts in a paradigm shift from just looking at anatomical and physiologic aspects and really honing into our larynx as a secondary sexual organ. There's been a bunch of research looking at hormone receptors, and we'll talk about that, but we know that women suffer more from dysphonia. It's evidence-based, and some people will say some off-color things about why, but truly there is physiological explanation for this, whether it's secondary to hormonal fluctuations throughout the lifespan, but also the underlying local vocal biology. We have shorter vocal folds, higher frequencies, higher pitch, more vibration, less dampening, and physiologically there's less hyaluronic acid as a result. So where are these hormone receptors? It's kind of a challenging topic because we're still really trying to figure it out. There's a lot of literature that identifies hormone receptors, but the question is whether their location really justifies their being active hormonal receptors. So if they're in the extracellular matrix or in the nucleus, different studies determine or figured or identify or define these hormone receptors as active when they're intranuclear, but other studies will define it as active if they're intracellular or extracellular matrix. And so we just don't have an idea of what is what, and so it's not really well established. But we do know that the effects and the fluctuations of the hormones do cause fluctuations in voice. And so when you look at these variations, such as high levels of estrogen can cause thickened epithelium, increased membranous channels that regulate the epithelial barrier, whether it's, I think aquaporins and mucus-secreting epithelial channels that can cause or reduce edema in the vocal folds, increasing lamina propria cellularity, particularly in pregnancy for estrogen. Progesterone, we're still trying to figure out, but we suspect that they also affect multi-channels in the epithelium. And androgens, which we can see and we know, because of our gender-affirming care and hormone replacement therapy, that they do cause increase in the thyroarytenoid muscles, cross-sectional area, and perhaps thickened epithelium, but no real change in the lamina propria or the extracellular matrix components. So we're looking at our 19-year-old gentleman who comes in with change in pitch versus our female patient that has fluctuations with her menstrual cycle. So typically when we are approaching puberty, we expect increase in androgen for our male patients, vocal tract and larynx increases, thickness and length of the vocal folds increase. That causes a decrease in the fundamental frequency or the modal pitch. It's initially pronounced, but then for the men, it typically stabilizes throughout their life, and we really don't see any significant impact from a hormonal standpoint until, the elderly or older population. But for women, it's different. Vocal tract and larynx decrease in length. We have a thickness and length that also decreases, but that results in an increase in fundamental frequency. But this is not stable, like monthly, hormonally, we're changing, and our voices may be impacted and vary throughout menstrual cycle. And then you have that permanent change when we go through the major changes. So this is our 38-year-old singer. Sudden loss of high range mid-cycle. She comes in, her voice, she says, is strained, a lot of roughness, less intensity, more fatigued, loss of higher tones and harmonics. And so for this exam, you could see she has a lot of tension, first off. She has a little bit of edema and some hypervascularity, and we'll see an image where on narrowband imaging, which is kind of like an ocular histologic exam, you could really appreciate that hypervascularity. And this fluctuates, so this is usually known as premenstrual vocal syndrome, and we'll talk about that a little bit more. But patients come in with this presentation. She has a bunch of allergies that are seasonal as well, right? So we're not thinking mainly hormonal, and patients aren't just like a box where you just put them into the perfect puzzle piece and it's a perfect fit. We have to look at the holistic aspect of it, but also we can appreciate that, okay, mid-range cycle, she's a singer, this may also be related to her menstruation. So premenstrual vocal syndrome is a term that is described by Abitol again, and it's also known as dysphonia premenstrualis, where patients may experience fatigue, weaker, huskier voice, loss in tone, and pianissimo, inability to speak in softer tones. Abitol showed similarities between laryngeal smears and cervix smears in variations in that menstrual cycle. Ferguson et al., and there was another group out of Turkey that actually demonstrated that there were sex hormones, specifically estrogen and progesterone receptors, on the vocal fold epithelium, and that affects the edematous component of this cycle presentation. And there's also speculation that they affect the musculomucosal complex, causing microvenous dilation, edema, can also cause LPR. Progesterone causes lower esophageal sphincter relaxation. So in pregnancy, that is dramatically increased. I'm speaking from experience, but you may notice a little bit more irritation or reflex around premenstrual, and then less lubrication. And also laryngeal, abdominal, and intercostal muscle tone are also affected by the estrogen and progesterone, so that may result in decreased breath support. And so this is that image that I was talking about with the fluctuation. So as estrogen decreases, you have increased permeability at the level of the epithelium, resulting in increased edema and also more vascularity that's noted. And I don't know which one's the pointer. At any rate, you can see in the luteal phase, when the progesterone is increased and the estrogen is decreased, that bottom image correlates to the laryngeal presentation. And in the luteal phase, you have more edema, and on narrowband imaging, you could see the increased vascularity. And so estrogen and progesterone work together to relax smooth muscles, induce venodilation, and then there's more polysaccharide breakdown that causes vocal fold congestion and edema. And then the progesterone can cause dryness and increased desquamation, as well as decreased mucus secretions on the vocal folds as well. There's also some evidence to support the fact that it could have a functional component. Many women that may suffer from premenstrual syndrome may have some mood variations and abdominal spasms. And so the question is there a component of laryngeal muscle tension? And because of the abdominal pain and spasms that may ensue, is there also secondary decreased respiratory effort from that as well? So how do you manage these patients? Like I said, you're not gonna be like, oh, you're on your period, let's manage that. You wanna definitely get a good history and be mindful of other influences that could be affecting the voice too. But in a professional voice user, that's the patient that's gonna be like noticing those subtle changes that could be impacted. And you may wanna be mindful of this propensity towards hypervascularity and the vocal fold hemorrhage risk. We've seen it, we've been very, very sensitive to it, but we may want to consider that that may be impacted by the premenstrual cycle and the vocal load that they may be experiencing during that time, about day 14 to 21 of their cycle. And so a lot of supportive care, hydration, humidification, and close contact with the laryngologist or otolaryngologist to make sure that things are status quo. Pregnancy, similar to menstruation, you got congestion, edema. The fundamental frequency in the second trimester actually decreases when you have male babies. I have 3. I think my voice did get a little deeper afterwards. It goes up after 2 years in a study by Lee et al., but it never really goes back to your baseline fundamental frequency. You also have reduced breath support because of that mass effect. And like I mentioned before, you have the reflux component as well. The other thing is there's a lot of open mouth breathing because of the pregnancy-induced rhinitis. So you want to make sure that these patients stay fully hydrated. So next case, 55-year-old executive, 55, let's say 65-ish. Voice just doesn't carry anymore. She reports strain, roughness, less intensity, more fatigue, less loss of higher tone. So this patient comes in, I'm expecting to see some wicked atrophy, right? Some glottic insufficiency. So that's the expectation. I'm ready to talk about vocal fold injection, maybe some therapy as well. But you scope her, and actually her cords don't look too bad. She's got some, thickened secretions on the vocal fold, so we can talk about some vocal wellness there, and maybe a little bit of edema. But now you're stumped, right? Because she doesn't really have any other symptoms, not really complaining of reflux. Her cords don't look too bad. So this is where you want to bring up the conversation about where we are, are we dealing with a menopausal picture? What are we dealing with this patient? So patients with menopause have increased perceptual strain, roughness, reduced vocal intensity, maybe some fatigue. These patients have reduced estrogen, inflammation, edema, some vasodilation. We don't know what the effects of estrogen are on the vocal folds, but usually in this patient population, especially with aging voice, atrophy is something that we can't neglect or forget about. So how would we manage this patient? Similar to the patient that we talked about before, we're probably not as worried about vocal fold hemorrhage in this patient population, but definitely one thing that we can consider, especially now that with the resurgence of hormone replacement therapies in the menopausal population, with now knowing that the risk is not as severe as we initially thought, considering hormone replacement therapy in this patient. So 2000s, late 1990s, hormone replacement therapy wasn't poo-pooed upon, and they actually found that patients that utilize intranasal hormone replacement therapy had better voice outcomes. So there's this Aerodiol that was once marketed, but now it's discontinued in the United States just simply because there were supply challenges, as well as it wasn't as, it was more expensive than the pills or the patches, so they discontinued it off of the market. But I'm wondering if it will make a comeback because it was very useful on the voice, but there is some evidence to support that pills or transdermal hormone replacement therapy can be as effective. This replacement therapy causes increased glandular secretions, enhances mucosal viscosity, improves capillary permeability, helping to reduce that edema and congestion. And so it's certainly an option for patients that you may want to have a discussion with, and maybe they discuss with their PCP or their endocrinologist about starting hormone replacement therapy if they don't have anything else underlying that is treatable, like atrophy with vocal fold injection. And gender-affirming care has been commonplace in our practice. Again, we're not the ones typically prescribing androgens for this patient population for transgendered males, but they often come to us for secondary voice therapy as adjunct treatment with their hormone replacement therapy. And transgendered males do really well with the testosterone because it does have that mass effect in increasing the TA muscle and causing that modal pitch to deepen. Transgender females a little bit more challenging. Estrogen is really not effective. Oftentimes they can get away with speech therapy alone. And hormone replacement therapy is not something that we do commonly recommend in this patient population, but there is some evidence to show that it's not the estrogen that impacts the voice, it's that secondary effect of reducing the testosterone, but that takes years to actually have a significant impact. Most commonly, patients get better results with the Windler's glottoplasty, but again, speech therapy alone can be effective as well. So, clinical pearls, voice changes and subtle nonspecific laryngology findings. You may want to consider, have a discussion about hormonal impacts, whether their menstrual cycle varies with their voice changes, are they on hormone replacement therapy, and even underlying medical conditions, polycystic ovarian syndrome, thyroid disease, even diabetes. Those can have impact on the voice as well. Professional voice users are going to be the patients that are going to notice these fluctuations in voice more, so early detection is key to avoid any detrimental impact on the voice. Menopause, it's not just aging voice. don't run in there and want to do an injection laryngoplasty, you may want to consider hormone replacement therapy or them having a discussion with their PCP about it. And testosterone effects are significant and they are irreversible when it comes to pregnancy with boys or when you're implementing testosterone therapy for your gender affirming care. Thank you. Those are my boys and their friends.
I'll have our panelists come up. Thank you, Dr. Sinnett. Yeah, your patients are going to ask you about hormone replacement if they haven't already. Hot topic, lots of research coming now that, we're talking about it a little more. Along with Dr. Sinnett and Dr. Smith, we're going to bring up Dr. Ian Bowers as our moderator for our panel. He is a laryngologist currently at Creighton University who trained at McLaren Oakland for his residency training and the University of Miami for his fellowship. I got these two, Aton and Ian, and they both trained at Old Pontiac, UCSF, with Clark Rosen, who I also trained with. So sorry about that, Ian. And then we have Dr. Aton Kadar, who is currently in Michigan as well at Corewell Health and serves as an assistant professor at Michigan State. And he also, like I said before, trained at McLaren Oakland, and he's the one that actually did his fellowship at University of Miami. So I'll stop talking now.
Thanks, Lindsay. Thanks, our panelists. Let me get my good laser pointer out, because I do love a laser pointer. So we're going to go over some cases with the panel here. I had to try not to just pick really complicated laryngology cases, because I just wanted to see their thoughts on my worst of the worst things and try to keep it relatable to a lot of our comprehensive ENTs out there and make it as useful for everybody. So I do not have any financial disclosures. I kind of called this my phone a friend cases, because these are the ones that I get called the most about from some of my former co-residents, other colleagues in my area. So I figured these were some hot topics to go over. These are our panelists again, which Lindsay already introduced, so we'll just keep moving forward. So case 1, 65-year-old female, active smoker, 1 pack per day for 30 years, in general good health, who presents with progressive dysphonia and cough over the last 12 months. I've always had a deeper voice, but getting significantly worse. You scope her and you see this. So our pretty straightforward looking Ranke's edema. My questions for the panelists are, will you operate on them if they are still smoking? Yes or no?
No. I won't, just because, so if they're coming in with dyspnea, then that's a horse of a different color, and I will do, a debulking, and, we're worried more about airway than voice. My concern is, obviously, if they are still smoking, that their voice is going to probably deteriorate if I do anything like microflap or treat it, and then they smoke on top of my surgery. And it's also going to recur. So I tell them if they quit for at least a month or two. Cotinine testing is a thing, but I've never tested my patients to see if they're telling the truth. But I know some people that do, but I take their word, and if they're able to quit for at least a month or two, then I'll consider surgery for them.
Yeah, I'm probably pretty similar. I mean, the hard part is that they will say, yeah, I quit for, 2 weeks before the surgery, and then they start back up a week later. So, at a certain point, it's tough. Really the goal is why now, right? There actually are studies. There was a study out of Cleveland Clinic that showed that there was no adverse effects doing Ranke's microflap surgery on people who are still smoking. Now, I don't remember how much people were smoking for that study, but it takes up to 8 weeks for the nicotine to get out of you. So, if they have really bulky disease like this, I'll be a little bit more apt to break my rule and be like, sure, we'll do it, but we're going to be really conservative. and a lot of discussion that it's really likely this is going to come back, and then we'll get to do it again. And I'll tell you, each time I do it, you get less from it. So the first surgery is the best surgery, and the next surgery is never quite as good. So, because you've got now scar and stuff like that. So it's a lot of patient counseling, and then it's, you know, a little responsibility on their side too.
I agree with that, everything that both of you said. The only thing I'll add is I kind of get a feel of what they're really there for. Hopefully it's I just want to make sure I don't have cancer and I don't have to get into the whole voice discussion. So if it's one of those, then great, and I would probably just monitor it, but I agree, I wouldn't want to potentially make the voice worse with the surgery.
So how long do you have them stop for?
I mean, in a perfect world, I would say 8 weeks. And usually during that time, depending upon how you have the conversation with them, they'll realize that it's important that they pull up their end of the bargain. But in the end, I mean, I've definitely had people who probably said they quit and then they didn't. Or, you know, like they planned their surgery for 2 months out saying, I quit yesterday, right? And then you find out that they haven't quit. And they actually do fine. But, you know, the question is there going to be a higher risk of them needing to have surgery again? Needing is a strong word. It's really wanting, right? It's a quality of life from a vocal fold, or, you know, voice quality aspect.
I had a patient post-op vape in the room after. So.
Now, vaping is better than smoking, but, right. You gotta be very specific.
Yeah.
And that actually is something that, you know, you have to ask your patients about marijuana use. And, you know, I always say, I always say, I don't care what you do, I just care about your vocal folds. So if you can take an alternate route of ingestion, if you can eat it, not smoke it, that's preferred, right? But I've actually started having a conversation with folks is like, yeah, you have to be careful about taking too many gummies at once, because that's actually the only way you can overdose on marijuana. You won't do it smoking, but you'll do it on gummies. And so I got that tip from my husband, who's an ER doc, because we don't see that, right? But yeah, having those conversations with the patients is good. And then they know that you're a real person. And so I think that they then feel a little bit more connected. So when you say, yeah, you know, let's hold off, let's see if you can do better on your smoking, they might be a little bit more apt to follow that.
How do you ingest the marijuana? Is it a vape? Is it a bong? Is it a glass piece? And they're like,
You're knowledgeable.
knowledgeable. No, but then you're more likely to get like honest answers out of people. I mean, they're like, it's not just some stuck-up person who doesn't know anything about that. So
it's like it's being non-judgmental.
yeah,
That's the key.
and I always tell them, I always give them the option too that I won't write it in the chart if you don't want me to. I just want to know the truth. Same with like if you notice somebody like cocaine use and stuff. Like I just need to know so I don't have to get biopsies of this. So you get them, you know, a lot of times what I'll say is I'll be like, oh, I was worried that you have cancer when you first came in. I'm glad you don't have cancer. I don't want to see you with cancer. So maybe this is the opportunity to quit smoking. So you get them to quit for 2 months. They come back. Yes, you trust them. They've quit. So for this one here, I mean, are you going to start them on any preoperative meds? Are you going to put them on any like reflux control? Say they don't have like an outstanding history of reflux, but do you put that on there to start? Do you do a steroid pack before you take them to surgery? Any preoperative medications?
I don't. That's not something that I've trained doing or currently do. I think the biggest thing is not smoking. You know, it might be you might also want to rescope them after 2 months, because one thing I counsel patients on is your voice might improve if you stop smoking. Sometimes stopping smoking is the only thing you need. Obviously, there are some cases where you do want to you're going to end up doing surgery, but I don't think I would put them on any medicines unless they were indicated. If they had symptoms of it, I would treat it like LPR, but I'd probably want to rescope them depending on the severity of the disease.
I gotta tell you, when everyone walks my clinic, they get a scope. Like it's a non. So I would definitely rescope, but I always tell them that the damage is done by quitting smoking. It just doesn't get worse, but it's not going to get better. So this is where your voice will probably be, unless we end up doing something. And yeah, we used to give antacid medicines to everyone. I give them to no one now before surgery. And so I don't think that that's needed. We're trying to get people off meds, not put them on.
I think I called you once about that. I'm like, do you do that for every microflap? Because we used to do it for every surgery because we're like, oh, we don't want to mess it up. So we just throw everything to mitigate any kind of inflammation afterwards. But I agree, I've been a little bit more judicious about, you know, the PPIs and stuff like that afterwards. But I think one of the things that we also need to take into consideration, and I read Abibtal, the Parisian laryngologist, talked about in his anecdotal textbook, what are the patient's expectations? I had a rapper come to see me and was concerned about his voice, had some Rinkies, and you know, when you do the surgery, you're gonna change the quality of the voice, right? So some people might like that deep raspiness, and you have to be cognizant about the fact that you may change their identity, right, of who they are. So you need to be very upfront about that, especially if they are professional voice users and performers, that look, your characteristic voice is gonna change. So just another conversation to have.
So, what approach are you using for this? This person right here, they came back, looks the same. Are you doing that cold steel, laser? You're gonna do one side staged? Do it both at once? What do you think?
So again, when I started at Pitt, I used to call Libby for, what do you do? So I used to do laser.
Awake or asleep?
Asleep. It depends. You know, if they have a lot of comorbidities and we can't go to the operating room, it's not a lot of, you know, significant polyps, then I would consider doing it awake, but mostly asleep. But now I've switched, mainly because the patient population has a lot of significant Rinkies, but also I like the outcomes when you do a nice little microflap. It's a fun surgery. I'll do both at the same time. I won't stage them. If it's not a lot of disease, then, you know, I may consider just doing a laser in the office if the patient can tolerate it. But microflap under general, bilateral.
Yeah, I always tell them I'm gonna do both sides, but if I don't like how one side went, I'm not gonna do the other. So Ranke surgery, microflap-wise, cold steel, is like, it's really artful, right? And so the key is you have to leave a certain amount of superficial lamina propria, all the goo in the SLP. You have to leave some of it. You can't just take it all out. And in the books, they show these beautiful pictures of like line drawings of just sucking out stuff. And it sometimes doesn't work that way, but it's a matter of trying to get a contour of that vocal fold, but still leaving some stuff behind, which is really hard to do, right, conceptually. And I always tell them, I'm like, I will err on taking too little out rather than too much because I can't put it back. Unless you keep smoking, I guess. Then that will help bring it back. But I don't tell them that part. So I'll say that I'm gonna do both sides, but if I don't like how one side went, it's done, right? Because I can always come back another day and do the other side if needed. I don't like, personally, the laser. I was, you know, about 10 years ago, there was a big push to laser everything, and I had to give someone an emergency airway because they had had laser done by somebody else, not Sandra, and that changed it for me, right? So laser is tricky because you don't have the same control and you don't know how the tissue is going to react to it, and you'll get this like post-laser inflammatory response, and you'll get a bunch of edema. So like, how much do you laser, right? How far do you go? And so I think if you can take people to the operating room and do it under cold knife, I think that's a better surgery, at least in my hands.
I'll do my plug on the laser. Maybe I haven't learned my lesson yet, but I'll, you know, but you could, you know, if you were going to use a laser, if you're, you know, you kind of debulk the disease. Sometimes a laser can be nice to kind of, I call it like a shrink wrap effect of the excess mucosa. Sometimes you could put it in, if there's like a lot of SLP, you could put it inside the SLP, and it kind of.
So you make like an incision, then you actually stick the laser fiber in there?
Yeah, well, this would be like after like a microflap, you're trying to cut stuff away, but there's just a lot in there. You could kind of put the laser in there, and it kind of has this light spreading effect that kind of shrinks it down. But err on the edge of caution, definitely.
So that's interesting. That's like doing the laser inside the vocal fold versus outside the vocal fold.
Yeah.
right. So that makes more sense, because in my mind, because that's no different than like sucking out with a little suction or plucking out and cutting out small amounts. I mean, these do usually really well. We saw the next picture; those do different, but these folks usually do really well.
Do you use KTP? Blue? Okay.
So then how does it change when it looks like this? So this one I was obviously too kind of concerned, like, is this a neoplasm? Did end up being Ranke's, got in there, it was nice and soft, but it was like multi-loculated. So I'm looking at this and I'm like, how am I gonna raise a flap around those big, like those, exophytic or pedunculated parts of this Ranke's? So how does that change for you guys? How would you go about approaching that?
So can I go back really quick, because this brings up a good point. When you do your cardotomy for Ranke's, we oftentimes talk about when we do microflaps, we put it right along the edge of the lesion, right? Which is what I would do for that next one. But like this one, there's no like actual lesion, right? So I tend to make mine a little bit more lateral, not all the way lateral, but maybe like along the superior surface, because one of the things about Ranke's is that it's the accumulation of SLP along the superior surface. And so when you have them like pant, you'll see it like there's like wings of tissue flopping into the airway,
saddle bagging.
Right? And it's really fun to watch. And so you basically have them do that. And so it's all this stuff on top. So instead of making my incision more lateral or more medial, I'll actually make it more lateral. Now this next one, I think that one you treat more like a regular microflap. And the fact that I would go to wherever that lateral extent is, you can't save that mucosa. It's going to be gone, right? So what you can try to do is try to dissect off the inferior aspect of it off of the mucosa and try to save a little of inferior mucosa so that you have less space between the edges. That's what I do. Would you laser?
I'd probably go cold steel and try to cut it, and then laser any excess stuff.
Nice.
Is there ever a role for a microdebrider? No. Never?
That sounds aggressive. That sounds scary. I don't know, I like to cut things off, so I'll probably do that. Would you microdebride?
For this one I did, and I was really glad I did.
So you microdebrided on the
Just
inside or
no,
the outside?
Just took the outside and then you ended up with, and then just cut the edges at the end.
Okay.
So that could have been, because I was trying to dissect it out, and I'm like, no. I was like, I'm not gonna be able to get around these loculations or like these, pedunculated parts.
Okay.
And it turned out really well. I was like, all the laryngologists are gonna hate me, but I'm gonna be honest about it. It worked out really well.
It's no different if you're careful, right?
Yeah.
You probably used a skimmer blade and not a tri-cut and all that kind of stuff. So it's no different than just trying to debulk it so that you can get around it, right?
Yeah, and then it was able to trim up, didn't tear the mucosa.
Interesting.
So I don't know.
Have you done that before?
Once before actually, but it was really, it was bad. Like it was even worse than this. I couldn't find the picture for that patient.
These are sometimes really hard. I had a guy, the only time I ever see guys with Ranke's is when they have this kind of disease and it's like a polyp on top of a polyp on top of a polyp, like there's like 3 of them on a side and you really just take one off, you're like, oh, criminy, there's another one. And then you take the next one off, oh my gosh, there's a third. And so I just work through those like stepwise, take one off, take the next one off, take the next. But the microdebrider for these, that's an interesting idea. It would definitely be faster.
And then say you see one like this. So obviously this one I was like operated on before, but now we're not seeing a whole lot of airway there. And then how does that change your approach for this patient?
So this is a tough one, and this is, Libby kind of touched on this in terms of when you have to leave enough like SLP and not take too much. There looks like there's some scar. There's like post-surgical changes on the left. There's some scar in the middle, and my worry would be if you take too much and make the right side look perfect, you're going to make a worse voice and they'll have some glottic insufficiency. So for me, I'd probably take some of the stuff on the superior surface of the left. I probably would leave or shrink down with the laser that posterior left kind of bump, and then I would be pretty conservative on the right side. I would probably make an incision, suction some of it out on the, or cup force some of it out on the right, and then laser it down a little bit. I wouldn't want to take too much. I would treat it more like like a airway problem and less of a voice problem. Because I think if I took too much and made the airway perfect, they would have a worsening voice from that.
I agree with that. I think sometimes you see these airways and they're breathing fine, you know, so I think that that's one. And then the second part is this is a pathology secondary to smoking, so breathing also includes pulmonary, you know, parenchymal function. So I'm very realistic about underlying COPD, emphysema, and things like that. I could fix only one part, you know, but there might be underlying lung issues, and so that needs to be taken into consideration. But if there was a role for surgery for this particular patient and they wanted it, I would probably leave the left side alone and focus on in posterior aspect of it to open up that posterior glottis and get better airway. That left side looks scarred. I don't know where the vocal fold is posteriorly, so I don't think that we would need to address that, but I think maybe opening it up on the right posteriorly may be beneficial for an airway standpoint.
Yeah, I think this case is a good example of what are the goals of the patient, right? So I'm always amazed, and Sandra alluded to it, these folks will come in and there's like no airway and they have no dyspnea complaints. It's phenomenal, but it makes sense because it all just opens and closes, right? It's like a little door, they just open and close, and it's pretty easy to do that. Now, oftentimes with those folks, after surgery, they say, wow, I had no idea I was short of breath, because they're so used to it, it kind of started so slow. This one's really hard, and you said it too, because that left side is so abnormal, right? The right side, that one's easy to take care of, easy-ish. But the left side, that one's a toughie.
Steroid injection and kind of leave it alone
Yeah.
would be a safe thing.
Yeah.
Do you ever get scared of losing the airway in really bad Ranke's edema? The only time I ever grabbed a knife in fellowship and was going to do like a slash was a really bad bilateral Ranke's, and we went to, mask them, and they were not maskable because the Ranke's collapsed in.
Yeah.
So do you ever take that into consideration for your Ranke's? I mean, you may not see it often that it's that bad, but that case sticks in my head every time.
I always try to show the airway to the anesthesiologist if there's any concern, because we have a higher threshold for stuff like this, but if they see that, they might freak out. So I'm always very transparent, like this looks bad, but technically they're intubatable, right? It's soft, so you could put a tube in. But yeah, I'm with you. I think that there's always a plan B, C that needs to be ready because you just never know when it's going to hit the fan. But typically, for Ranke's, I'm just transparent with the anesthesiologist that it looks like trash, but the tube should go right in. But I've never had it where they were not mask ventilatable. That sounds a little scary, but always be ready.
Yeah, but they were probably tubable, right? So I actually am opposite. So we have the same anesthesia crew, but I guess depending upon who my team is that day, I may actually not tell them because I know they're not going to see the vocal folds anyways. They're going to see their arytenoids and just shoot the gap. So as long as, maybe I shouldn't say that. But, well, because they're not seeing what we see, right? They never get that view. If you talk to your anesthesiologist and you have someone who will actually be honest with you, and you say, what did you actually see when you put in the tube? They will tell you, if they're honest, that they actually did maybe not even see the vocal folds. They didn't see the whites of the vocal folds. So they may not actually know that all this is going on, and sometimes that's a good thing. But it is true, you do need to have always a plan B as to what would be the next thing if masking isn't possible.
There was one case that I remember it was a tough Ranke's, and I wanted jet available. That was one thing I had available, but I've never had a non-maskable Ranke's patient. Talking about anesthesia, I did this in fellowship and I kind of carried it on, is I intubate my laryngology patients because an anesthesiologist is going to want to they just want to get the tube in the hole, and I think they could be a little aggressive, and you probably had experiences where you go to do a polyp surgery and the polyp's gone. So for this, this is something that I would want my team to intubate, preferably soft stylet so they don't lacerate this stuff, which is uncommon, but, that's something that
But these are super fragile, so if you just even basically rub up against it, it usually de-epithelializes, it basically splits.
Toilet paper.
especially with a glide scope, that stylet is very dangerous, so.
So I actually, as a parenthetical, I actually asked my anesthesia staff to not use the glide scope. One, it's a lost skill that people have, and sometimes glide scopes, you don't have them, or the light isn't working, or whatever, that actually using a regular Miller or Mac blade. And I think that there's less injury with that too, to your point.
So, moving on to case 2. So this is one I've gotten called about too from some of my former colleagues. So 55-year-old male, post-op day 3, status post-ACDF, levels C3 through C6, woke up from surgery with a breathy voice, dysphagia, and coughing. Significant aspiration noted on the MBS. NG tube is already placed by the time they consult you. They're considering putting in a PEG tube. On nasolarynxoscopy, has left vocal fold paralysis in the lateralized position. So you're kind of assuming a paresis. You don't think that, you talk to the operating surgeon, we don't think there was a transection. So patient of note tolerated the scope well. So how are you handling your inpatient consults for this? In this specific setting? Like, all right, well, either we're gonna try to do something or they're getting a PEG tube.
I'm injecting them. If not, whenever dysphagia is in place, I think that it's hard to not to in this patient population. At minimum, you'll give them improved cough and clearance, and then the secondary benefit of voice. And I'll start with like a Prolarin gel or a Renuva CMC to see what the vocal fold does. But I think that early intervention to mitigate PEG tube placement, especially for a procedure that, that's pretty excessive.
Really excessive.
Yeah, like give them a chance, see what they do, let them cook for a little.
Do you insist on a swallow study first?
No, I don't. I'll just inject them.
Are you doing it with them awake? Are you doing it at bedside? Are you doing it in the OR? What setting are you doing the injection?
So this is hard. If they're healthy, we can do it at bedside. The challenge is they just had an ACDF, so they don't have a lot of extension. But you might be, depending upon the body habit is and their tolerance, you probably can get away with doing it at bedside with their limited extension. And I typically go for thyrohyoid approach. Patients tolerate that really well. It's like sniper, get in, get out, done. And you improve their cough. Hopefully you have speech therapy on board inpatient that can work with the patient, and get them moving. I think the name of the game is rehab therapy, be aggressive, because time, is valuable in this patient population. If they didn't transect the nerve, then the expectation is for them to regain function pretty quickly, so.
Yeah, the ACDF is complicated because depending on how bad the disease was or what happened in surgery, they might not want to take that C-collar off, and that can block, I like the thyrohyoid too, but that might be a transoral, and and I would want to do it inpatient, even though I absolutely hate doing inpatient injections. I don't know, can you take them to your office and if they're on the floor? No. So, I would.
Just because of like the hospital bed or because of your scope? Why do you hate it?
We gotta get a tower, I would bring like a bronch tower, that's a whole
Why don't you
process.
just use like an ambu?
I just don't think I know it's distal chip, but I just don't feel like I could see as well as like an Olympus tower.
So you'll take the whole tower up?
I'll make the resident
You're
bring the
crazy,
whole
huh?
tower. And that's a sacrifice I'm willing to make.
Specifically.
So take the ACDF out of it. Say it's patient who woke up post-stroke, same situation. So you have doing it asleep much more easily available. I guess trying to relate it like to some people out there who don't have a resident or don't have an APP who's going to be able to drive the scope for them. They haven't done awake, don't feel comfortable doing it. Is it reasonable to take them to the OR and inject that side? Is that Is that still a reasonable way to go?
Yeah, so, I mean, 3 days after, well, I mean, this was an ACDF case, but, so if we keep the ACDF in there, I mean, there's multiple reasons for this person to have swallowing difficulties. Obviously, the glottic incompetence is a big part, but ACDF itself changes the swallowing mechanism. So, basically asking for that extra information from your speech language pathologist. Don't read the radiologist report, it's useless. Read the SLP report, and they should actually comment on like posteropharyngeal wall contraction and where's their residue and when was the aspiration. If it's during, that's glottic, but if it was after, it's probably because they didn't get a good clearance through, right? I mean, glottic can be a component of that, but it could also just be from edema from having the surgery. I will choose it based upon, I mean, if they've got frank aspiration, I think you're kind of compelled, you need to think really strongly about doing something. If they're not and they're just hoarse and they don't have the dysphagia component, I think you can actually hold off and just wait, right?
So that was going to be my next part. So vocal fold immobility, no dysphagia. Are you doing the injection while they're inpatient or no? But doc, I have to use my voice for work. Am I just gonna have to be off work for a few months until this comes back? Or is that a follow-up in clinic?
I would do it in the hospital, well, because I can do it awake and at bedside, but I wouldn't, not general anesthesia for a more quality of life thing. I think that's risk-benefit. I don't know if I could justify that. But, I mean, it's challenging, right? Because if that's the patient's livelihood and they need it, thank you. I think it's situational, but I'm probably going to lean more towards would like to do it awake at bedside if it's just for breathy voice and no dysphagia. And it could wait, really,
So then I've had questions like, well, if I'm doing it asleep, how do I know how much to put in? And in this type of situation, I always kind of thought of it as, well, if you're going to do something that's a short-acting, like Prolaren gel, Renew gel, if you overdo it, it doesn't really matter as long as you're not, compromising their airway. If you're trying to just close it for, glottic competence, for dysphagia, then you don't really need to worry. If you overdo it a little bit, their voice is tight, then it will get reabsorbed by the body. You're trying to get them through this period of time. So I did like the picture from the phonomicrosurgery textbook. Kind of shows exactly where you want to do your injections and kind of what you want it to look like bulk-wise afterwards. So just helping out for any of the people out there who don't do these often. It can be kind of helpful.
Do you inject into the muscle or do you inject lateral to it?
I try to inject into the muscle.
Okay. So I tend to inject more lateral, but I think your volumes will change with that. Sometimes you have to fill the paraglottic space before you'll get a medialization bump, but we don't always know exactly where we are, but you can go into the muscle, but you can also go lateral, I would say. So it really doesn't matter.
Are you ever giving nimodipine in these type of situations?
That's something I've not used, nimodipine, it's a calcium channel blocker.
Yeah, so just a background, there was some evidence, some papers that were done that showed that you had a better chance of spontaneous recovery on a stretch injury to the RLN, so you can try to give those in the early period, but it is not an easy medication to get, and sometimes can be very expensive for the patient. But I had to throw it out there because we have, Libby's on these papers, so.
Yeah, so the studies were basically looking at folks who had laryngeal EMG that showed a really poor prognosis for recovery of vocal fold motion based upon the findings. So I wouldn't advocate nimodipine for all patients. It really should be for the ones that are have kind of been shown to be bad. It is a tough medication to get. It can range anywhere from $0 to $1,500 a month, depending upon your insurance, and it's sometimes hard to locate. It's a 3-month course. I usually see people back monthly during that. What we showed was that in those patients who have a historical recovery rate of 10 to 20%, when they were on nimodipine, that actually went up to 60%. And so getting motion back is huge, right? And because that's always going to be better than what we do. And so yeah, I'll still use it, but you got to get these people early on. And the original studies for this came out of Sweden, and their setup is that their laryngologists are literally right next to the endocrine surgeons. So when they feel like they've been plucking around the nerve too much or they injure it, they'll actually start them on nimodipine IV right then and there. And so that's kind of where it all started from. So I think that there could be value to it, but if you don't see him for 3 months, because what happens oftentimes is surgeons will say, no one wants to think that they hurt the nerve, right? And they'll say, I saw it, it was intact, so it's gonna come back. And sometimes it doesn't, right? And so you have up to a year for it to recover, and so we'll see people sometimes a year out, and they've been struggling for that year, and it breaks your heart, because you're like, there's so many things we could have done, but that's not an appropriate patient for it's off-label nimodipine.
A question for you. Do you use that for idiopathic or after like an actual injury, stretch injury, or both?
It's a really good question. So I think that when I look back at who we're doing laryngeal EMG on, we have a lot of nerves that are injured during surgery. So our patient population is anywhere from like 70 to 90% iatrogenic. So they usually end up being that. But it's an interesting idea. If it's idiopathic, everything should be continuous. But I would say if they had an EMG and they were in that poor prognosis group, and if it didn't cost them $1,500 a month, sure, why not? Right? But I think that that's a really small subset of who we see.
My personal hesitancy is it's the blood pressure problem, and I've offered it to one person, and they were like a young person with idiopathic, and I felt good about that, but he didn't want it.
Yeah, but they're actually the young ones are the tough ones. You actually want them to have some blood pressure issues, so they're already kind of working high. I mean, if you've got someone who comes in and their blood pressure is 110 over 60, you know, they're already running low, or 100 over 60, yeah, it's going to be tough. And there is about 25% of patients that do not tolerate it. So it's a high non-tolerance.
I think the other thing too, I had a patient that was insisting on nimodipine, and they were PEG dependent though, and nerve injury from surgery, and PEG, like doing it through the PEG, the absorption is different, and that can cause a precipitous blood pressure drop versus the PO formulation. So you just have to be mindful of that too, especially, it's probably a rare incidence, but under those circumstances.
So I mean, I acknowledge that probably almost no one in here has access to laryngeal EMG. So where you could think about it is if you have a transection, because you know that's the most severe injury and you're not going to get motion back. But the question would be is, and we don't know the answer, is that are you increasing the chances of being able to get synkinesis, which can maintain muscle bulk and potentially, since there's more adductor nerve fibers in the RLN, can you get a little bit of adduction of that vocal fold, which is what reinnervation, that's what we hope it does. So I'll use it in those cases without testing.
So, third case, 67-year-old female presents with progressive dysphonia over the last 3 to 4 years, complains of a weak, unstable voice with lots of cracking. I don't feel like talking anymore because no one can hear me. Denies pain, denies dysphagia. Voice is somewhat breathy with lots of glottic fry. On strobe, you note some bowing of the vocal folds, but near complete closure with effort. So let's see if my video works. So a little anterior gap there. Didn't get any volume. So, kind of like a mild, moderate vocal fold atrophy. How are you going to approach this patient? Are you going to offer augmentation up front? Are you going to do voice therapy first? Are you going to look into other things? How are you approaching this patient?
I guess at first it depends on in what setting I see them. So if
outpatient,
so
otherwise healthy person.
If my my speech language pathologist saw the patient first and she worked with them, and she was able to, they were very stimulable to a better voice with just on that evaluation, I would probably offer voice therapy first. If she says, you know, we really weren't able to get anything out, I would still offer voice therapy, but I would say, hey, listen, I don't know that it's going to help much. We could always do it and kind of open the door to a temporary injection.
Yeah, I totally agree. I think one of the first questions though I ask is after we see the exam and I talk to them about, you know, just aging voice in general, it's not all just the vocal folds, it's the body too, right? So there's changes in the respiratory system and there's things that won't get changed with augmentation, so it's not always a grand slam. But one of the first things I ask them is like, hey, great news, you don't have cancer. Like, are you good with that? And about 30% of folks, we looked at this, are like, yeah, I'm good. Like, I don't actually need anything else. I just am, ultimately, I was worried that I had cancer. And once you allay that fear, then a good portion of folks are like, I'm good. But yeah, I always think that voice therapy, if they've got enough to work with, and this person looks like they do, I mean, they look like they have some decreased tone of that vocal fold. That mucosal wave was a little bit increased and a little bit haphazard. And so the question would be is, you know, if they're a therapy candidate, I always say you can't hurt someone with therapy, right? And so that's a good place to start. Now, if they have like really severe atrophy and there's nothing to work with, then I think then augmentation, you kind of move that way faster.
If they're getting closure, I'm pretty much like, okay, you're going to do voice therapy first, and even if we don't get what we want, that's going to set you up for success in the long run. So let's do that. So then, say they come back from voice therapy, they're like, yeah, doc, I worked with them for like 2 to 3 months, kind of plateaued. I'd kind of like to do something more. I need some projection in at the bridge table because nobody can hear me. What are you doing?
I would inject. I would obviously consider underlying pathology as well, like Dr. Smith mentioned, but patients do really well with in-office injections, and I would offer either short-acting or long-acting and have them understand that there is another option if they want a more permanent solution, which would be a medialization thyroplasty. Most of my patients do well with the injection, and you know, I've switched from Prolaren Plus to Juvederm, and they do well with that for about 8 months. And it doesn't require a lot, like for atrophy at least. Most of my patients, it's like 0.2, 0.3 cc's on both sides, and that'll last them 6 to 8 months, or 1 month if we do the Prolaren Plus, and then we decide from there if they want to do Gore-Tex ablation.
Yeah, so I would just, yeah. Prolaren
I do
Plus.
Prolaren Plus only at the VA because I can't get Juvederm.
Yeah, so I would be cautious with the Prolaren Plus. And Sandra and I have talked about this, so this isn't like not news. That there is a pretty strong inflammatory reaction with it. And the way that it was created was the idea was that there are these little spherules of CAHA, calcium hydroxylapatite, and you would cause a little inflammatory reaction and create this little fibrosis covering over each one of those little balls, okay? And then when the CAHA wore off, the fibrous cover would still be there. So it was actually billed to be a permanent augmentation, which would have been awesome. Turns out that's not the case. So what happens instead is you get inflammation over the whole glob of stuff in there. And so then I think of it like what I find, and talking to others, they found it too. I don't know if anyone's actually published on it yet, but that after you inject like 3-4 times, you just don't get as much because you're working up against that fibrous capsule that you've created from your CAHA injections. So great now that the hyaluronic acid products are more available because they last a little bit less, but they don't have that intense inflammatory reaction. And then when you want to do a thyroplasty, I actually prefer fat injection for these folks usually, but whatever it is that you're going to do, whether it's one of those two, you're not fighting that capsule, if that makes sense. So I like to start with a temporary. I usually use actually the CMC products. It'd be the Prolaren gel and the Renew gel, because there's a percentage of these folks that I always say, yeah, you've got skinny, floppy vocal folds. I can make them fat and floppy, but there's a certain portion of folks that do not like that. And so I purposely want to do something short. So we'll do it as a trial. and with the idea that if your voice, deteriorates after it, that we can move on to something else. Interestingly, I haven't been able to get it published, but I'll tell you guys that when we looked at our atrophy patients, a third of them never needed, their VHI, their voice handicap index, which you want to have a low number, improved after augmentation, and in a third of them, it stayed low.
After you're saying after like a trial injection?
After it's gone away.
Or like a short-acting filler?
Correct. So
I've
like
noticed that anecdotally.
Long term, there's again about a third of patients that had persistent improvement despite expected resorption of the medication, which is why I like the CMC products, because I know in 3 months it's gone, right? The HA products, there's a little bit more of a window, so it's like, when is it gone? So I'll start there and then move on if we need to.
I've seen one really bad inflammatory reaction with the CAHA. It was actually a doctor, so that was kind of hard. And it was got better after a few months, and we treated him with steroids. But at the VA where we have Prolarin Plus, I haven't seen, and it's been working really, really well. We also use it for injection pharyngoplasties for velopharyngeal insufficiency because of the viscosity is better. If we did like HA in that area, it would just absorb and I think you got to work with what you got, unfortunately, and I tell them on the front end that the inflammatory reaction is a risk with CAHA, but so far it's been okay in that patient population. I think the vets are a little bit more amenable with wiggle room with a little rougher voice, but I don't use it for professional voice users. I avoid it as much as possible.
I do carboxymethylcellulose for a trial and/or Restylane. In fellowship, we use a lot of CAHA for this. A lot of that stuff. I've over discussions with other laryngologists. Some concerns of the CAHA is that it can cause some stiffness of the fold. So I know there's been discussions like if you're going to do an atrophy patient with CAHA, do you stage it?
Yeah.
Like do one side, see how they respond, make sure it's not stiff, and then do the other. Because if you end up stiffening both sides, and that could be a bigger problem.
And if CAHA gets in the wrong layer of your hose, so I stopped doing awake injections just because I haven't been able to train my my APPs to give me a good enough view. So I had one that was a superficial, and I was like, well, I'm not doing this again. So if I'm doing CAHA, I'm pretty much doing it asleep unless I have no other choice. Because I want to be confident that I'm getting it in the perfect spot.
100%. I've had to take CAHA out of that superficial space multiple times, and the vocal fold's never quite the same afterwards.
No, you have to be careful with that.
So I did want to show this last one here. So this is a situation like you were talking about where they're just getting nothing. It is so atrophied that there's no appreciable vibration. They're totally aphonic. What are you going for this? What are you going to offer this patient when you see them in the office?
I'd probably push more towards like a trial injection with a follow-up, more permanent or semi-permanent procedure after that, like fat or thyroplasty, probably thyroplasty.
I would just go straight to fat, if they have it to give.
That's a good point. Yeah, I think that I have the discussion with them, and we kind of make a joint decision together if they want to trial it or if they want to go to the OR and do a more permanent procedure. Fat, I want to love it, but in my hands it hasn't been as good. So I do Gore-Tex, and that I would stage. Sometimes I can get away with a unilateral Gore-Tex, but this is pretty significant, so I'd be prepared to do bilateral if we need to. But definitely shared decision making with the patient on how they want to do this.
So I'll give a pitch for fat. So this person lacks all the soft tissue that they once had. And the thyroplasty implants conceptually are hard, right?
They don't, Gore-Tex don't vibrate.
I mean, Gore-Tex is maybe slightly more forgiving than Silastic, but they're both really hard. So what I'll do for these folks, I'll be like, okay, that's a huge gap. Now, I've had someone like this is even worse, and I just did one fat injection, and he was awesome. But I always say, I need to give you something to work with. So think of the fat as that. And if we need to, we can always do a thyroplasty later, but you gotta have something to vibrate with. Right now, you don't have that. You have nothing squishy in there to vibrate. So I'll pitch it as a 2-stage, but maybe I've been fortunate. I haven't had to do the second stage. So they usually do pretty well with that.
Single injection?
Both sides?
But I mean, not doing multiple?
Yeah, just one usually. Now I always tell folks about 1/3 of patients don't have enough fat survive, because that's like the issue with fat, and that's why people don't like it, which is fair. But out of that 1/3 of patients, I'd say only half of them lose all of it, and they oftentimes have enough where they're like, actually, I'm way better, because this person has no voice, right? I mean, they got nothing, right? So if you give them something, they're probably gonna be really happy. They just need something to work with, right? And they'll probably still be raspy and not sound good, but it's way better than the effort that they're exerting to try to talk on this. So you can repeat it though.
Do you soak your fat in insulin? And if so, how long do you keep them after surgery?
Yeah, so I soak it in insulin. It's a whole lot of insulin. And then I keep them for 4 hours afterwards to monitor their glucose levels. And usually about hour 3, they drop, and we know that, so we're kind of giving them orange juice and stuff like that so it doesn't drop as bad. But we worked with our endocrinologists to see how long it would take for them to have the effects from the insulin basically wear off, and they recommended the 4 hours, so we do that. And that basically started because we had a case of, it was actually Dr. Rosen's patients, who basically looked like they were stroking out, and it turns like they were just hypoglycemic with a sugar of 30. So, yeah, so we keep them for the 4 hours afterwards.
The insulin helps stabilize the fat. So if you're anticipating about 50% of it, I mean, that's what I counsel my patients. I'm like, we have to over-inject because 50% will not take. So the insulin kind of gives you, theoretically gives a better chance of, of the lipo injection staying and keeping that bulk. So, yeah, I agreed that I did fat on him. Yeah. So, anyways, we're at the end. So I would like to thank all of our panelists. It's been a great discussion. We'll all be around if there's more questions, but we got to keep things on time, I'm told. So, thank you all for your attention.
All right, guys, we're going to move right along into kind of the pediatric airway section of our day. I have the honor to introduce Dr. Stephen Ingebretson. He was one of our residents at the Detroit Medical Center and just an absolutely fabulous guy. He then went on to do a pediatric otolaryngology fellowship at the University of California, San Francisco, and now he practices at Valley Children's, which is in Central California, and has an interest in the ear, but also does the full spectrum of pediatric otolaryngology. And today he's going to speak to you about intracapsular tonsillectomy in the pediatric population.
Thank you. Happy to be here. As Dr. Wendland mentioned, I actually was hired into Valley Children's in Madera for my interest in specialists in cochlear implantation and ear surgeries. But of course, our careers sort of shift and change as we move along. And I found myself essentially giving the talk I'm about to give to you to many of the people in the hospital, some of my colleagues, and have apparently become the go-to expert, at least in the Central Valley, on intracapsular tonsillectomy. So I figured this would be a good topic to discuss, not so much to reiterate all the research that's out there. I think that a lot of people, especially if you're here interested in pediatrics, have seen some of the data and the improved outcomes with intracapsular, but really to go through the sort of mental exercise you may go through as a practitioner in your personal practice of, do I want to go into this? Do I want to start this? And how do I start this if I feel so inclined? All right, let's see if I can do this properly. How do I advance this? Oh, the wrong green circle. I was doing the laser. So I have no disclosures. My only disclosure is that my wonderful family has been along this ride with me, as many of you have experienced through the many different places we've been, and they are now trying to live our best lives in the Central Valley, where we in the shadow of Yosemite and the sequoias and things. The goals I'd have today are to first understand the sort of difference between the techniques, which should be pretty straightforward for this group, understand the different aspects regarding pain, bleeding, regrowth, cost, which is more of a newer understanding, display these sort of different techniques, and I have a video I'd like to talk about what I do and how I found that successful, and then understanding how to clinically apply this to your own practice. It'll be no surprise to the people in this room, there's a lot of tonsillectomies done. I always thought in training that we were going to run out of tonsillectomies to do in Detroit, but they just kept coming. And so this is obviously a very impactful surgery. To briefly cover the main question, which is, does this impact, does leaving a little bit of the tonsil tissue also put them at risk for residual sleep apnea? The answer is no, it's exactly the same. When you look at the studies that have been done, there's been some great systematic reviews, meta-analyses showing that by removing 99% of that tonsil, the effects on sleep disorder breathing and OSA symptoms are essentially the same. And there is really little drawback to there. And the AHIs in those papers sometimes go up as high into the high 30s. I don't put a number on it, and we'll see why in a minute, but it's important to recognize that that is really not it shouldn't be a discussion, but that's part of the mental barrier I find myself, or I did find myself in when first applying this. Of course, the other benefits of pain reduction, lower hemorrhage risk, and return to faster oral intake are always balanced with this discussion that everyone likes to bring up, which is the risk of regrowth. So I put this in here. This is AI helping me put my thoughts into words. So I have found that one of the biggest challenges talking about this technique with families and doing it in a way in which I can still see my 30 patients a day and get through these discussions and not prolong my consent is to really find a way to really get them to conceptualize all the data that we understand, that we're going to go through a little bit here, and buy into this idea of why I think this is a better procedure for their child. So I've landed on the orange with an orange in an orange peel. This seems to help them understand it. I literally do, and sorry, I'm not trying to explain it to you so much, but this is literally what I do with them. I show them the orange and the orange peel, and that it protects all the blood vessels and nerves and muscles over here, and then by removing that but keeping this, we protect those things. And that seems to settle, that takes like 6 or 7 minutes out of my discussion with them, because all of a sudden they understand the anatomy and what it means. And it makes sense to them when I say, I'd rather do that than leave everything exposed. The risk is there's regrowth, but the benefits outweigh the risks. We'll get into that. So let's talk about pain quickly. It's no surprise to this group or anybody that tonsillectomies hurt, and opioids reduction is a big topic of research recently and really for a long time. Everyone has varying practices as far as how much opiate they give, or if they give any opiate after extracapsular tonsillectomy. There's some research from the dental literature that shows up to 6.5%, 6.8% can actually have a persistent, prolonged use after procedures that require opiates. And then, of course, there's always the concern about bleeding after tonsillectomy with ibuprofen use. I find it generally safe, but there's good studies out there that show that if you use that alone, that you're going to have an increased risk of bleeding. And so, of course, this management of pain is always a concern. I used to quote in residency that, oh, it's no problem, we're giving you 3 days of opiates after tonsillectomy and we're going to minimize those risks. Don't worry about it. It's going to, to make them feel better when they're giving it to their kid. But the research actually bears out that about almost 4.8% of kids that have a tonsillectomy may end up having prolonged use of narcotics in the future. So it's not a non-zero problem. Let's quickly talk about the bleeding and dehydration components. when it comes to intracapsular tonsillectomy, the number I quote to my patients is I say less than 1%. That's a little bit of me selling it, but the reality is it's pretty much true. It's 1% or less bleeding risk after tonsillectomy with the intracapsular technique compared to our, if you even want to be conservative, 2 or 3% risk, maybe 3 or 4% risk depending on the age of the patient regarding the extracapsular technique. The other component we think about with pain is why they're coming back to the emergency department, the calls we get in the middle of the night, or if you're lucky, have residents get for you in the middle of the night, as far as the patients being readmitted to the hospital. And the graph on the right here is a great review here talking about these clear differences between how much time they, or how much they return to the emergency department for bleeding, or sorry, for pain or dehydration compared to the extracapsular technique. If I have any PIT fans, you'll recognize these two individuals. So this is a really fun episode if you're an ENT. Hits all of the traumatic experiences, but also a little bit therapeutic. So I want to pause here and talk about, we talk a lot about numbers, a lot about our quantitative data, but in my other interest world, there's been a push for more qualitative data, which has been really useful for those in the hearing loss community. I wish we had more qualitative data on tonsil bleeds, because every one of us could write a great paper on like the horrific experiences that you've probably had with a near-death experience with a tonsil bleed, or even a tonsil bleed that's not that bad, that the parents definitely feel like this kid is going to die, even though it's probably mild and you can control it with TXA or something. But I like this image because it shows you that just nobody's having a good time in this experience. The patient is not having a good time, the doctor's not having a good time, especially when you get vomited blood on you. And really this slide was just to show that I wish there was more qualitative research, but there's a lot of limitations on why we can't do that in a tonsillectomy bleed. And so in place of that, I'd like you to place your own anecdotal experience. I apologize for being less scientific, but I think that's the best we can do. And think about this question, which is really, at what point does this risk of regrowth outweigh this post-tonsillectomy hemorrhage experience? How many post-tonsillectomy hemorrhage experiences are worth the regrowth rate, et cetera, if you understand what I'm trying to say. So this became a leading question in my mind when I was finishing training and starting my own practice and deciding like, well, which patients am I really going to offer this to, and which patients am I not going to offer this to? So let's talk about it, this tonsil regrowth. I like this study that was actually most recently published in 2026 because I think this is a good summary of what a lot of the other data shows. A lot of the other data will have numbers between like 1, 5, 6% regrowth rate, just depends on their population, how their study was done. This is what I quote to patients. I say somewhere between 1 and 3% risk of regrowth. And if you listen to the real experts in the field on this, who have done the research, they will tell you that as the kid gets older, it's probably closer to 1%. So if I have a 10 or 11-year-old in my office and I'm offering an intracapsular tonsillectomy, I'm telling them, listen, technically it's 1 to 3%, very likely it's closer to the 1%, just because the chance of you regrowing this before adolescence and before adulthood, when it tends to shrink anyway, is much lower, compared to the 2-year-old, who is probably a little bit higher in risk. And usually if this is going to regrow, it's going to happen in 3-4 years down the road. So the other argument you can make is that you've given them a lot, even if they are in this regrowth pattern, you've given them a lot of time to grow, get out of that young childhood era where a tonsil bleed or these concerns would be actually really, really concerning. This same study showed a really interesting trend when they adapted in their group over like this 9-year period. When you first start, your regrowth rate might actually be higher than what is published, and that makes sense because when you're first doing this technique, the exact way in which you do it, sometimes you get a little nervous about, am I going too deep or am I not getting enough? So you tend to err on the side of safety. And you tend to leave a little more tonsil than you probably should. I wish that we would rename the term intracapsular tonsillectomy to subtotal tonsillectomy because that's really the goal. I mean, you really should be removing all of the tonsil tissue and only leaving that little capsule. As you see here, though, as the time went on, they noticed that the revision rates actually went down to less than 1%. Now, a little bit of research problematic there, right? I mean, it's towards the end of the study, and so they probably haven't seen as many of the kids later on. But either way, you can see the idea that it's going to decrease over time. Kids that you would definitely want to think like, oh, well, there's a decent chance of regrowth, maybe 3 or 4%, would be kids that are under the age of 4, kids with a history of GERD or other conditions that are going to cause inflammation and potentially cause this regrowth, or a indication which it is okay to do this surgery for recurrent tonsillitis, with the understanding that they regrow it, they again have a little chance of getting that infection risk again, and so they have a little more chance of regrowth and need another procedure. I want to make a quick comment on our vulnerable populations. I'm using the trisomy 21 to sort of encompass all of our complicated kiddos, basically our genetic syndrome kiddos, our craniofacial issues, or anything where we'd be concerned that there would be more risk of complications after. Taking a tonsillectomy out in a trisomy 21 is important. It happens a lot. It also personally you just feel like kind of a jerk because they don't understand more than most what's going on. They tend to stay in the hospital for pain and discomfort. The studies were first started out in Stanford a few years ago showing that this proof of concept basically that you can do this in a trisomy 21 patient and they have good outcomes. And the research continues to kind of be added upon. It is a little bit of a mental shift for me, and it may be for you too. My thought is they're trisomy 21, they're gonna have large tongues, they're gonna have circumferential collapse, they're gonna have residual OSA. I wanna get every little bit of tonsil out of there so that I can do what I can to try and minimize the post-op OSA. The studies, though, if we get out of our anecdotal experiences, show that there really is no difference between the post-op and the pre-op compared to the extracapsular versus the intracapsular techniques. And I personally, in my own practice, I am waiting a little bit longer for a little bit more data before I run at all of my trisomy 21 kids with extracapsular or intracapsular technique. But I think it is something to note that it's probably the right thing to do, and it's probably something I'll be moving my practice towards more, certainly in the kid that is moderate OSA, trisomy 21, but we'll get into that criteria in a minute. So this is more of an interesting one. So this is always something that comes up. There's a couple of ways to do intracapsular tonsillectomy. There's the microdebrider way, which you just bring it down and then use the suction bovie, which is acceptable, or there's the powered way with the co-blader, which is my preferred method. And the discussion is always, well, the co-blader is like $200 and a bovie's $10, or a snare is $15, or whatever your other method of choice is. So this has always been a discussion of, well, it costs too much, and it's hard to sell maybe to administration saying, hey, at an outpatient surgery center, like we want to buy these expensive instruments. Well, luckily for us, there was somebody who decided to dive into this economic data and compare OR time and staffing, surgical supplies and instrumentation, PACU recovery and nursing, and readmission rates and ED visits. Between both extracapsular and intracapsular techniques. They were using the co-blader, so that's the more expensive of the tools. This was actually ended up being a triadilogic thesis for this physician that published this, and the whole article is very dense and very interesting to read, but it's got some economic math that I will admit I am not an expert in. And so I have hopefully summarized it down to the things that I think matter, at least to an admin. And the way that we talk about these costs are that we actually find that intracapsular tonsillectomy is cost dominant, which sounds really awesome when you say it that way. But the reality is in an ambulatory setting, over time, when you pull these patients together, you save about $700 per case. And the reason that makes sense is just the pure cost of a return to the emergency department or a increase in time in the recovery due to pain can all add up over time and actually cost more for the system than these intracapsular techniques who tend to have less pain and be able to get out the door and have less hospital and readmissions afterwards. They did a similar comparison between the inpatient population, but that gets a little bit harder to compare just because of different comorbidities. But essentially what it came out with is it was a smaller margin, but still cost effective. But even if it broke even, that still argues towards the idea of it's not cost averse to use the intracapsular technique. One of the things I thought was very interesting is this sensitivity threshold, where at what point would the intracapsular tonsillectomy become more expensive, and that would be about 14.5% of a regrowth rate. So taking the patient back for another surgery, 14.5% of the time, which is far below far above where we've talked about the average regrowth rate is as well. And so this just is, to me, was kind of the last sort of piece of the puzzle where you'd say, oh, it's all the reasons why I can't do it in my institution. I'm hopefully knocking down those barriers at this point, and which are here on my next slide. And a few years ago, there was a survey done of pediatric otolaryngologists and how many people do this routinely, and it was only about 20%. I assume it's higher now, but I will tell you just a few years ago in fellowship that it was always one of my favorite sort of sinister things to do, which was on a grand rounds with everybody, and pediatric grand rounds, I would just throw out a little tidbit about a certain technique of tonsillectomy. Didn't matter which one, because everyone had every technique at my institution. They all had different opinions. And just to like kind of watch the wolves go at each other in a very professional, loving way. But it was every single time, and it was so entertaining. I would even tell the residents, this is what I'm going to do, and then that would happen. And because everyone has the way that they do it, and it makes sense because you've done so many, it's hard for us to think like, well, maybe the other technique is better, or I'm not so sure how I feel about that article, or I'm not so sure how I feel about, you know, this, and my experience with this, and my bleed rate's lower, which I love you and respect everyone in this room, but I will just tell you, you're wrong about your bleed rate probably. You probably have more bleeds than are reported, because it's hard to catch every single one of them. Unless you've got a really excellent system, come talk to me after, where you're catching 100% of your post-ops with phone calls and finding out if they bled. There's probably some you're missing, and I think we have to just at least trust the data in those sorts of circumstances. The other component is that the guidelines from 2019 didn't even address it. They specifically said, like, we don't want to talk about it in the guidelines. I think that they update it and fairly in 2019, because I think in the last 5 or 6 years, there's been a lot of really good research that's kind of shown us this way. And then this mental barrier, I think, is the last thing, this risk of regrowth, this idea that if we're leaving a little tissue and it regrows, I've failed the patient. And then we, on the other side of things, say, well, tonsillectomy and postoperative hemorrhage is a risk, and so we somehow accept that. Let's think about Dr. Whitaker from the pit and the spitting of the blood and everything, and take that qualitative experience, compare it to this idea of, like, we're so scared of regrowth. So this is what I did, and it was hard when I first started. When I first joined my institution, I was a little bit of the pariah. I was the young guy, and I was the only one that came in thinking, we're doing intracapsular tonsillectomies, and I would do these, and the staff would ask me, the surgical techs, the nurses, I mean, no joke, probably for a year, I was explaining every single day, multiple times, sometimes to the same person, but why am I doing intracap and using this instrument, and you have too many foot pedals, Dr. Ingebretson, and why are your partners not doing it? Which is a really awkward conversation, because I love and respect my partners, and I'm like, I don't know, you gotta ask them, but this is why I do it. And then the APPs who are signing up surgeries, like, well, which patients do you want us to sign up? And we've gone through a little bit of this. There's lots of data showing, oh, it's great, it's less pain, it's less bleeding. Okay, but like, for every patient, or just should I do it for some patients? Now, there are some excellent zealots and those who are doing the research in the field, those who, actually one of Dr. Shorney did the cost analysis, who actually do it on 100% of their patients. They'll go so far as actually even in lymphoma cases to take a biopsy and then just remain and do the intracapsular tonsillectomy. I don't agree with that personally, but that is just to show you that there is that spectrum, and there's a lot of people doing that, and they find that acceptable. This is what I landed on. So, and this is what I gave my APPs. Mild to moderate OSA with a normal-ish weight. In my mind, there's literally no patient in that group that should not be offered an intracapsular tonsillectomy. The only patients in this group I'm doing a total tonsillectomy on are the patients where the parents are saying, I'd rather have it all the way out, I'm old school, let's just do it. Okay, I'm not gonna argue with you all that much. But those are the kids that are really easy for my APPs to sign up and just offer it right off the bat. They can have the conversation with them. They're talking about oranges and orange peels, and it's making it a little bit easier. The next category is this yellow shared decision make group, okay? And I will admit that the vast majority in this group, if I'm talking to them, they end up getting an intracapsular tonsillectomy, but it is a little more nuanced. And the easiest thing to run into is the obese kid, because we got a lot of them, and there's there's this, okay, they're over the 99th percentile, but then it comes down to a little bit more, I hate to say it, nuanced sort of art of medicine components. It's not quite as data-driven in my practice, other than the fact that I know I can trust the data for intracapsular tonsillectomy. And what I mean by that is, if you look at a sleep study, and the sleep study shows 0 obstructive apneas and 120 hypopneas, and they have 4+ tonsils and 4+ adenoids, the chance I'm gonna cure that kid, even if they're obese, is really, really high, because the hypopneas are likely from these monster tonsils and adenoids. And so in that situation, I will almost guarantee to offer intracapsular tonsillectomy, because I think it's gonna help them greatly. And I don't think I'm gonna be considering more advanced techniques in that patient with like a modified pharyngoplasty or anything like that in my initial surgery. Recurrent tonsillitis patients, I will personally say I, for the most part, will still do extracapsular tonsillectomy, because I think it's a little higher risk. These people are miserable, and they are on the same page that they want it all the way out. They don't want that higher chance of a second procedure. But again, the data says otherwise. You can do it. I know I'm sort of playing devil's advocate here, but I'm trying to tell the reality of what I practice compared to what's actually out there in the data. And then the kids that are the stop and consider extracapsular are sort of the obvious ones. If it's for a chronic infectious etiology, or if it's like a PFAPA or neoplasms, it's coming all the way out. Or the kids that are very severe OSA. And I don't put a number on it, but you know which kids those are. They've got hypercapnia on their sleep study. They've got an HI of like 60 or 70. I'm gonna take the tonsil all the way out, mostly because I want to make sure that I have the option, even sometimes into the surgery, to do an extra stitch, like a little modified pharyngoplasty, do a UPPP on some of them. I don't do that many in the kids, but I wanna have that opportunity to be able to do that. And so that, in my mind, I haven't been able to shift to all intracapsular for 100% of my patients. Those are the patients I still feel like deserve the extracapsular. Again, always open to other people's opinions, and I know that the experts in the field that have done all the research may actually disagree on that one. So I wanted to talk about just a little bit of the techniques here. I'm gonna list them out here, and then we'll go through a video that I did. So the biggest time saver, which is the other concern most people have when learning this, is to resect, like just lop off half the tonsil right off the bat, because it'll save you about 50% of the time of eating away every little bit. Use a moderate pressure, quick movements with the co-blader. You're looking for that yellow capsule, and it also, you see the yellow and you feel it. It's just a tighter, tougher feel. And then my one trick, I hope I'm as cool as I think I am, is that using the cauterization with the flush of the co-blader. It's like a flush and a suction. The co-blader is kind of an interesting tool like that, to help get these small pockets of tissue. And then at the very end, this is something I do. I don't know if it makes a difference. I have no research behind this, but I take a suction Bovion 20 and I just fry the capsule. And I've been asked actually by one of my partners, doesn't that cause thermal damage? I don't think so, because I'm just crisping the capsule. If I haven't gone through, it's really just I'm just trying to cause scar of that, but I don't see any heat going through causing more pain. I haven't seen any increase in pain doing that. The herd retractor being used as sort of a lateral palpation, because if you're not taking any anterior pillar out, sometimes it's hard to see kind of around that corner. You can kind of switch it around, which also leads to grabbing the posterior pillar and sort of flipping it out at yourself so you can really see all along where that capsule is. So here's a tonsil in all its glory. This is a routine case I did a little while ago. So this first technique here you'll see is just lopping off the tonsil. You can go relatively quick here. Just basically don't go fast enough or so fast that it bleeds a ton. And you lop off about 50% of the tonsil. Just really quickly saves a lot of time. And you'll see then that immediately that posterior pillar is going to be pretty visible as soon as this little piece comes out. And then I'll usually grab the posterior pillar, define it, and be able to see a little bit better around the corner and to really get that tonsil tissue out. So you can see all the white tonsil tissue and then the yellow. What you'll see in a minute here, it'll freeze frame, is the coagulation setting, the different petal right here with the white that comes out. You're going to see that's, oh, I know there's more tonsil tissue. I did this for the purpose of the video, but sometimes it's hard to tell. There's pockets of that little tonsil tissue. We know there's sometimes they go little crypts. And that really has made a big difference, is my like getting every little bit out. You just do a little bit moderate pressure, do that coagulation, and then it will show you that there. You can do coblation again until you get to this point here where I'm scraping on it and like it's not going any further. You can tell that I'm not taking anything away. And then my final check too is to take that herd and really just touch the lateral anterior pillar and see, like, you can feel the difference in bulk, right? Like you do in a peritonsillar abscess, you know where the plane is. That plane is pretty much gone because there's like no bulk anymore. And so this is why I really feel like I'd rather call it a subtotal tonsillectomy. I mean, it's really, you're trying to get every little bit of it out and really crisp this thing up. So in summary, we have all the benefits. The research shows all the benefits. It's decreased bleeding, decreased pain, decreased opioid use. I don't give any of my intracapsulars opiates, and most of them end up telling me that it was really quite little pain. I never say painless, but they're always very surprised because they've all had family members have had stories of how terrible tonsillectomy is for them. And then the cost benefit of the instrumentation is pushing us toward this way, and this sort of long-term outcomes have been relatively well proven. I know this is not a perfect comparison, but I do tend to think of it as sort of like a open surgery versus laparoscopic. It just sort of makes a lot of sense that if you want less morbidity, you would do a laparoscopic surgery, but there are times when you just can't do that. And so I really try to keep it fluid, keep the art of medicine in mind when I'm talking to these patients. If they're really opposed to the idea of any chance of coming back, then I quickly just kind of go towards, well, all right, we'll take it all the way out, right? We should be facile in both techniques. And I think it's a really good tool for any general ENT or anyone that sees kids at all to have sort of in their back pocket. So think about it if you haven't already. Any questions? I used the werewolf and then the halo. I don't know who asked that. That was like from the, okay, yeah.
Can you give kind of a scenario of something, if they do have regrowth, what does that look like when they come in? Are they symptomatic?
Yes, so I tell them, and I tell the parents this too, I said, if they have regrowth to a point that matters, right, because they can have regrowth, but it won't matter. If they have regrowth to the point that matters, where they're having sleep disorder breathing symptoms again, that's what you're watching for. And they know what to watch for. You have all the same things you're seeing is what I tell them to watch for. I will tell you I had one case early on that had I redone this again, I would have said no. But I did an intracapsular, and then like 3 months later, they came back like, no, there's still symptoms, and the tonsils regrew. And I was like, oh my gosh, what am I doing? I'm crazy. I was like 3 months into my practice. And so I said, okay, I'll take you back. I took them right back, did an extracapsular, took out the littlest nubbins that were left. And then they came back 2 months later and they said, well, we're still having symptoms. And I was like, gosh, dang it. So I think sometimes we can convince ourselves if we see it that it's because we left this little tonsil. What I really should have done, but we have resource issues, I should have just said, okay, hold on. Before you tell me that, let's get a sleep study and see what's actually happening. So of course we got a sleep study after the full tonsillectomy, and the kid was fine, but the symptom, they didn't match up, right? And it was just the parents being overly concerned. And that was an early regrowth thing that does not happen often, although I've heard about it in other colleagues. But I think a lot of times we have to just sort of, it's our fear. It's our practitioner, oh my gosh, I've done wrong on this. In this new technique, I should have done it differently. But in reality, I tell them, if you're going to see symptoms again, if it's really regrowing to a point, that's a problem. Yeah?
When those quoted regrowth rates, are those based on recurring symptoms, or are they based on objective visual?
Those are based on, those regrowth rates, those are based on needing a second procedure. And so, because I can look in, and my post-op note now just says like minimal tonsils, because you can see a little bump in the fossa now, like, yeah, there's tonsil left there, but I don't count that as regrowth. So those rates they had regrowth to the point where they had symptoms again, and they needed another procedure. Good question. Yep.
Counsel parents on HPV vaccination and calm fears regarding increased risk of
Right. That doesn't come up often in our population, but so I don't have that discussion regularly. But most families don't have that on their mind. I tell them they should all get vaccinated because that's just how I feel like they should do. But that's a separate topic. All the kids should get vaccinated for that. Yeah. Yeah, I mean, that is my practice. So we're the only hospital in 200 and something miles. Yeah, we've got Bay Area stuff, but I mean, that's 3 or 4 hours away from most patients. So this is a real consideration. And I would come back to, I know I'm trying to finish, sorry, Krista, that, you know, I've had that brought to me by a friend and colleague from another institution saying, well, these kids are waiting a year to see you, which is true, and then sometimes longer to do surgery. Just take it all the way out so they don't have sleep apnea if it comes back. My flip to that is, if they bleed in this rural community, they are very likely to die. I mean, I'm not trying to be dramatic about it. I've had more times at my institution, kids being flown in with life-threatening bleeds than I ever had in training and things, just because they're in the sticks and they didn't know, and they're going to some community ER that just freaks out because they don't know what to do, rightfully so. So to me, it's actually an argument to do this. I've heard of some practices just completely switching. Everyone is required to do intracapsular tonsillectomies in their group because they want less bleeding risks, and I don't think that we're hurting patients by doing that. Last question. Oh, here we go.
You know, newer data has suggested that ketorolac is probably a little bit more efficacious in immediate post-op pain control, and the bleeding risk is probably not as high as we thought in the immediate post-operative period. Are you offering that in your intracapsular tonsillectomy patients in the immediate post-operative period?
Great question. I would love to. My institution had a heart attack over this. So that is one of the battles that I am trying, because not all of our providers agree, and so they wanted to standardize it. So now we give no Toradol. It's actually been locked up by the anesthesiologist, no joke. It's a totally separate administrative problem, but yes, 100%, especially in intracap, give them the Toradol. Like, they are gonna be great, their pain is gonna be even better. I've even had some folks do injections to decrease the pain. They're walking out without any pain. So yeah, I'm totally fine with Toradol, but you know, hospital's not. Great, thank you.
I'm just curious, how many people are doing intracapsular tonsillectomies here? So it's definitely catching on. I know, I always love it when I put ear tubes in the kids because you get to see actually what happens over the next year or two. All right, so I have the pleasure to introduce Dr. Sophia Khan. She is a gastroenterologist here at Phoenix Children's. She did her residency here and then went on to do her pediatric gastroenterology fellowship at the University of Cincinnati. She is part of the aerodigestive group at the Children's Hospital of Phoenix and is here to speak about GERD in the pediatric population.
Hi, everyone. I'm excited to be here. Thank you for that wonderful introduction. I'll be talking about gastroesophageal reflux disease in pediatric patients. I have no disclosures. So first, I wanted to define what is gastroesophageal reflux disease, and I think it's important to differentiate gastroesophageal reflux from gastroesophageal reflux disease, or GERD. So gastroesophageal reflux is just the passage of contents from the stomach into the esophagus. And then gastroesophageal reflux disease, or GERD, is when reflux leads to troublesome symptoms and or complications. The symptoms for GERD can vary based on the age of the child. So in infants, you're more likely to see crying, back arching, regurgitation, vomiting, or irritability. In older children, more commonly, we'll see things like vomiting, regurgitation, or heartburn. This graph shows the estimated incidence of rates of GERD in children, and I think it's important to notice the increased incidence in the younger children that kind of improves, and then over time it increases again in the teenage years. And I think that early period we'll kind of go over more. You know, a lot of children will have symptoms and have reflux, but may not have GERD, so it's just important to keep these numbers in mind. So there's several mechanisms that are in place that prevent gastroesophageal reflux. One is the lower esophageal sphincter, which stays closed at baseline, and then when you eat or swallow, it opens up so contents from the esophagus can move into the stomach. We also have the crural diaphragm, which is primarily a respiratory muscle, but it also has a sphincter-like mechanism for the esophagus, and it reinforces the esophageal sphincter, the lower sphincter. And then the pharyngoesophageal ligament that holds the esophagus to the diaphragm, and it prevents the displacement of the stomach superiorly, and so it is also part of the anti-reflux mechanism. GERD pathology occurs when there's, the primary mechanisms include transient lower esophageal sphincter relaxation and impaired esophageal clearance. Secondary mechanisms include increased intra-abdominal pressure, decreased gastric compliance, delayed gastric emptying, and reduced esophageal capacitance, and all of those lead to the development of GERD. The symptoms also vary depending on the age of the child as far as what they may present with. So as we discussed, so in infants, you can see poor weight gain, you can see feeding refusal, whether it's with bottles and formula or breastfeeding. Some kids will be very fussy and irritable due to discomfort. Some kids may present with Sandifer syndrome, and that's where they may have back arching or they may tilt their head. And they may have regurgitation with or without vomiting. In older children, we may see regurgitation and vomiting, but we also may see epigastric pain, heartburn, hematemesis, or dysphagia. As we mentioned that younger kids may have reflux without having GERD, so I think it's important to kind of look at the percentage of children that have regurgitation and vomiting over their first year of life. So in the first few months, it's very common. So as the chart shows, 41% of infants age 3 to 4 months spit up a lot of their feedings. But if you look down past the 12-month mark at 13 to 14 months, less than 5% of infants spit up most of their feedings. So it's important to realize that there may be a lot of regurgitation in those early ages that may not be causing discomfort or other symptoms. There's a lot of red flag symptoms that may be occurring, and if these symptoms are present in patients, then it needs more of evaluation, and it's not just simple GERD. So things like weight loss, lethargy, fever, if there's a longer duration of symptoms or the timing of symptoms don't make sense, would require further investigation into systemic causes of what's happening, of the vomiting or whatever symptoms they may be having, looking for infections, rheumatological conditions, those kind of things. If patients have dysuria in addition to vomiting, we want to make sure we're looking for urinary tract infection or other causes of the vomiting from a renal perspective. If they have nocturnal vomiting, that's very concerning. We're worried about increased intracranial pressure. If there's bilious vomiting that's present, then we want to think about anatomical abnormalities, malrotation. Is there a possibility of obstruction? Hematemesis may be really bad esophagitis or significant GERD, but maybe other things as well. Varices, Merrill-Weiss tears, so we'd want to think about that as well. If patients have chronic diarrhea or bloody diarrhea, we may want to think about inflammatory bowel disease, Crohn's disease, and the evaluation would be obviously different. And then abdominal distension, similarly looking for other anatomical abnormalities or Crohn's and those kind of things as well. As far as diagnostic testing for GERD, I think it's difficult to talk about this because there's no one test that helps us diagnose GERD. It's kind of an overall picture with symptoms and different testing and those kind of things. But I'll talk about a few of the things that we consider when we see these patients. So one thing that we think about is a barium contrast study, and that's more to assess those alarm symptoms and maybe for patients that aren't responsive to treatment that we would expect. It really assesses for other anatomical abnormalities. So we're looking for things like malrotation, hiatal hernias, esophageal strictures, achalasia, esophageal or antral webs, and then if they've had surgery like fundoplication, is there complications? Has that fundoplication is that still intact? These are just some cool pictures showing the different things that we may be looking for in a contrast study. So we see a hiatal hernia on the first one where you can see the stomach is kind of above the diaphragm and the contrast is going up in that direction. The second one shows a malrotation and you can see the small intestine is all on one side of the spine. And then the last one is achalasia, and you can see the dilated esophagus in that image. On a contrast study, you may see gastroesophageal reflux, but that does not diagnose gastroesophageal reflux disease. We also think about swallow studies for these patients that we see. It may be helpful for extraesophageal symptoms if they're having coughing, if they're having wheezing, if they have asthma, those kind of things. It helps us diagnose dysphagia and aspiration. In children, in pediatrics, it can be difficult to differentiate reflux and dysphagia just by reported symptoms or even observed feeding. So I think it's important to keep in mind that this may be something that you're considering, that the symptoms of GERD may be more like dysphagia or aspiration. And then for ultrasound, again, we're looking for other causes of vomiting. You know, in infants, we think about pyloric stenosis, which we may obtain an ultrasound for. We may find hydronephrosis, gallstones, or ovarian torsion. We also think about upper endoscopy with biopsies for these patients, sometimes with biopsies, sometimes without biopsies, depending on the patients. But you know, this helps us evaluate the mucosa. We can see things like erosive esophagitis. On the histology, we may be able to see microscopic esophagitis. We can see infections like Candida, fungal infections, even viral CMV infections. We can see eosinophilic esophagitis or EOE. If the Crohn's disease is affecting the upper tract, including the esophagus, we may see that. And then we can also diagnose Barrett's esophagus. It's not as common in pediatrics, but I have seen it in some older teenagers. It can help confirm the diagnosis of GERD if there are visible erosions seen on the endoscopy along with the appropriate clinical history. But just because you have a normal endoscopy with normal mucosa appearance and normal histology, that doesn't exclude the diagnosis of GERD. This just shows some pictures from our endoscopy. So the first one is a normal esophagus, looks nice and pink, looks healthy. We don't see any erosions, there's no inflammation, no irritation. The second one shows esophageal strictures, so you can see a little bit of narrowing there, and you also see irritation and redness and probably erosions from that stricture being there. The next one is eosinophilic esophagitis, and you can see a lot of inflammation there. You see that linear pattern, which we call furrowing, and you see a lot of exudate in there because things are probably not moving through as well because of all that inflammation that's there. And then the picture on the bottom, there is Candida infection, Candidal esophagitis, and you can see the plaques on there, and you can see a lot of redness and irritation under there. So that's usually pretty painful. These show the different histology that we see on our biopsy. So the first one is sort of a normal esophagus, and I put that there just so we can compare it to what we may see with GERD. So the second one shows what we may see with GERD, and you see basal cell layer hyperplasia. You can see elongation of the lamina propria papillae. I think the problem with this is that that's very nonspecific. We can see it with other conditions as well, including eosinophilic esophagitis, infections, or Crohn's disease, so it makes it a little bit difficult. The last picture is of an eosinophilic cell, which helps us diagnose in eosinophilic esophagitis if there's the right numbers present and in the right locations, but those are also seen in GERD as well in a fewer numbers. Next, I want to talk about impedance testing. So impedance testing has a high sensitivity for detecting reflux episode. Basically, it's a probe that goes into the nose and into the esophagus. It has impedance sensors in place and a pH sensor. And then the patient has like a box on the outside that they carry for recording purposes, and then they keep a track of all of their symptoms. And we usually leave it in for 24 hours, and then they can take it out after that. It helps capture information about pH, about how high that reflux is coming up in the esophagus, if there's liquid and or gas reflux going on. I do think that there are several limitations for impedance testing. One is that the reference ranges are difficult because there's not a lot of data on healthy controls. There's also diversity in the performance and reading of these studies, so that can also be difficult. There's also thought that when patients have significant esophagitis or inflammation, the readings may not be as accurate, may actually underestimate reflux. And I think in pediatrics, there's very limited data or studies showing that the testing and the results lead to clinical improvement, after sort of implementing changes. Another option is pH testing, which is more limited than the impedance testing. It's just like a single probe that's placed in the esophagus, and it measures pH. The patient still has an external box that they have to carry. They still keep track of their symptoms, but after a little while, that probe falls off on its own. And it only measures pH at that one location where it's at, so it's much more limited. But sometimes we can use it to help correlate symptoms with episodes based on the log that they're keeping. And it also helps us evaluate acid suppression. Is the acid suppression sufficient? Do we need to make changes, adjust the medications they may be on? This is just a chest X-ray that shows that impedance probe in place. You can see that there are sensors throughout the esophagus, and there's a pH sensor there that we usually get an extra after placement just to make sure that it's placed correctly and where we want it to be. Next, I'll talk about management, and again, management differs a little bit based on the age of the child, so we'll talk about infants first, and then we'll kind of move on to the older children. One thing that we can think about children that are breastfed or drinking breast milk or on formula is thickening. That helps regurgitation, but I think the data on whether it improves symptoms is a little more confusing. Some data suggests, parents report significant improvement in symptoms. Other data suggest that may not be as significant as the regurgitation. The options for thickening include cereal thickeners or commercial thickeners. So we can use rice infant cereal, oatmeal infant cereal. There's been some concern with the amount of arsenic in rice cereal, but I think overall it's probably safe, and there's newer versions that are low arsenic or no arsenic versions, so those are options as well. There's many different commercial thickeners that can be used based on the age of the patient. So certain thickeners are for younger kids and some are for older kids. And then if we're thickening breast milk, we want to use commercial thickeners and not cereal, because the cereal can be digested by the enzymes in breast milk. Another thing that we can think about is cow milk protein elimination, and the reasoning for this is because patients or infants that have cow milk protein allergy may present with very similar symptoms to reflux, like regurgitation and vomiting. So it's reasonable to try a trial of cow milk protein elimination, and that usually starts with extensively hydrolyzed formulas, and the recommendation is at least a 2-week trial, not changing the formula too often. And then the amino acid formulas are usually reserved if there's more severe symptoms, so we usually start with those extensively hydrolyzed formulas. If a patient is breastfeeding or getting breast milk, then we can talk to mom about eliminating dairy or cow milk from her protein, similarly for a 2-week period, and it kind of has the same effect of eliminating that cow milk protein. The other thing to think about in infants is overfeeding as well. That can definitely cause issues. So looking at the volumes, the frequency of feedings, and making sure that's appropriate for the age and weight of the patient. When we talk about older children, we have some other lifestyle modifications that we can think of. One is positioning, so left lateral positioning at night, or even head of the bed elevation can be considered. Usually those are not recommended in infants because of the risk of SIDS, so we don't recommend it for the infants. And then weight loss for obese patients, definitely counsel on that. We also talk about avoiding caffeine, avoiding spicy foods, citrus-containing foods, and then fatty foods or deep-fried foods as well. Thinking about limited, no food intake or no meal intake 1 hour prior to going to bed, and then also recommending smaller, more frequent meals instead of larger, big meals. Next, I'll move on to the pharmacological management of GERD, and that's a gastric parietal cell that you see up on the screen. So when you eat, there's a histamine release. The histamine binds to the histamine receptor, which then triggers the cell to release increased acid. So when you use H2 blockers, those block that histamine binding to the receptor and leads to decreased acid production. So that's one category of medications we use. And then the other category of medications that we may use are proton pump inhibitors. And so those act on the hydrogen potassium ATPase pump or the proton pump, and they bind to that pump, inactivating it, so also leading to decreased acid production. So like I said, two big classes of medications, think about the H2 blockers and then the PPIs. So if you have erosive esophagitis and endoscopy, then the recommendation is to use a proton pump inhibitor over a H2 blocker. If there's a contraindication, kidney disease or something else that the patient can't use PPI, then we would do an H2 blocker. The other recommendation is not to use either medication groups for babies that are presenting with irritability and fussiness and not other symptoms of GERD, so not just kind of using that preemptively. And then also if you have a patient or an infant that has a lot of regurgitation but is healthy otherwise, growing otherwise, also the recommendation is not to use these medications because as we saw, there's a lot of regurgitation sort of in those first few months of life. For older children that have classic GERD symptoms like heartburn, epigastric pain, you can consider a course of H2 blockers or PPIs for 4 to 8 weeks to see how they respond. If they don't respond or symptoms come back after weaning, then they definitely need an additional workup. And the recommendation is also not to use these for extraesophageal symptoms like coughing, asthma, wheezing, and those kind of things. As far as prokinetic medications goes, in general, those are not used as first line for GERD management. This chart or graph shows basically the improvement of erosive esophagitis on endoscopy for H2 blockers versus PPI. So there's definitely better healing with PPIs and a longer duration of PPIs, and that's why the recommendations if there's erosive esophagitis to really use PPIs, and that's where the endoscopy comes handy as well. But we use the H2 blockers, as I said, if there's a contraindication to the PPIs. Okay. So the next couple of slides are sort of the algorithms for patients that may be presenting with GERD, and they're divided based on infants and then the older child, and they're from the NASPGHAN clinical guidelines. So if you have a patient that you're suspicious has GERD, obviously you start with a good physical exam and history, and if you have any presence of those alarm signs or symptoms that we talked about, like weight loss, hematemesis, distension, then obviously the workup is different and they kind of go on their different path of workup, evaluation, and referral. If they don't have any of those alarm symptoms present, then in infants we can think about some of those non-pharmacological things that we talked about, so talking about overfeeding, appropriate volumes. We can try thickening feeds with thickeners or cereal, and then if that's improved, then that's what we continue with the management. If there's no improvement with those changes, then the next step is to consider a hydrolyzed formula or an amino acid-based formula, or have mom eliminate the cow milk from her diet. And if that leads to improvement, that we continue that, and at some point in the future we talk about reintroducing cow milk, usually around closer to 1 year of age. If there's no improvement after that, then the recommendation is referral to pediatric GI, and at that point we would think about some of those other testing that we talked about, and maybe even considering a trial of reflux medications for those patients. And then this chart is for an older child. Again, we're going to start with a good history and physical exam. If any of those alarm symptoms are present, they're having like diarrhea or weight loss or fevers, then obviously the PAT changes and they go down a different sort of workup. But if none of those alarm symptoms are present, then we can try some of those lifestyle and dietary education. So, avoiding the caffeine, avoiding spicy foods, the positioning, those kind of things that we talked about. If that helps, then that's what we continue. If there's not improvement on that, then it's appropriate to try acid suppression for 4 to 8 weeks, and that can be an H2 blocker or a PPI. And then, after that, we'd attempt to wean. If there's no improvement with the medication or symptoms come back when we're weaning, then it's at that time to consider referral for pediatric GI. And then from our perspective, when they come to see us at that point, if they're having symptoms on PPI or we're unable to stop the PPI, usually the next step is an endoscopy to take a look on the inside, make sure we can see what's going on. Now, if there's erosive esophagitis or eosinophilic esophagitis or something else going on, we treat that appropriately. Now, if they have no erosions, but they have symptoms on the PPI, the next step usually from there is like an impedance or a pH testing. And then, if we see abnormal acid exposure on that testing, then that's non-erosive reflux disease, and we treat it as such. If there's normal acid exposure, then we think of things like reflux hypersensitivity or functional heartburn. And then if there's no erosions on the endoscopy, but the patients are doing better on PPI, usually we'll continue it and then try and wean again at some point. Those are my resources. Thank you. Any questions? Thank you.
All right, next up we have Dr. Claire Richardson. Claire was one of my residents when I was at Case Medical Center in Cleveland, and she is a fantastic person, a very dear friend of mine. She went on to do her pediatric ENT fellowship at Seattle Children's, where she did extensive research in surgical planning. She now speaks all over the world on all kinds of complex airway conditions, and today she's going to speak to you guys about recurrent croup.
All right. Thanks, Carissa, and thanks for the invite, and hopefully we can all stay awake for this before our coffee break. So, as Carissa mentioned, I take care of a lot of airway conditions. Croup is one of the ones that you see more frequently. It's a little bit less exciting than some of the other ones, but one that I think no matter where you practice is going to eventually work its way into your clinic somehow. So, first of all, I don't have any disclosures. We're going to start with just a few basics. I'm sure all of you guys are familiar with seeing croup patients in your clinic, so we're not going to belabor it. We're going to talk about what our current treatment paradigms are, probably the ones that we were taught in our training, and then we're going to spend most of the time talking about, are there new things that have come to light with managing croup, and are these things that you want to incorporate into your practice, and then we'll end with kind of a practical approach to treating different types of patients with croup. So, first of all, croup is kind of a blanket term, like we use it to describe pretty much any viral inflammation of the larynx extending into the subglottis and trachea. So it covers actually a wide variety of viral infections, sometimes can range into the bacterial tracheitis too, but it's kind of the term that you're going to hear most frequently from families and from consulting people. And it's incredibly, incredibly common. So when I saw this number, and this is from a few years ago, talking about how it's 1.3% of all ED visits in the US, which is a crazy number, I think. And it's something that we see inpatient if you're covering the pediatric side of an inpatient hospital or outpatient in your clinic. And so inpatient, the focus is more on like acute treatment and getting them through their croup event. What we're gonna talk a little bit more about is what to do when we see them in our outpatient clinic. And instead the focus kind of shifts to what's causing this, how can we prevent it, and then what is the long-term kind of prognosis for these kids. So looking at who gets this, it's by far the most common under age 6, and a little bit less common in the really little ones and a little bit less common in kids older than that. It's definitely more common in males, and that's a number that has persisted through the literature. And then there are definite spikes of it that go on with spikes of viruses, and that's going to change kind of depending on your area that you live in and the time of year and the place in the world, but normally parainfluenza is the #1 cause of croup, and so that's typically fall-winter, at least in the United States. Also interesting to note, if there's a family history of croup, then your kids are 3 times more likely to have recurrent croup. Clinically, it presents typically with a viral prodrome, like you have cough, runny nose, typical viral symptoms, and then it progresses sometimes rapidly and sometimes over the course of a couple of days into that noisy breathing, stridor, barky cough that we all hear about. And then if it gets really severe, that's when it kind of turns into more of the respiratory distress picture, and that's typically what brings patients in either to their PCP or into the emergency department. And when you look at the majority of causes of croup, they're typically self-limited. So if you can just tough it out at home, if you can get your families a good plan on how to manage it, usually within a day or two, it's starting to get better on its own. And the hope is that we can increase the number of patients, families who can do that so that we can decrease that humongous number of ED visits that they're having. So now we are going to talk about some current treatment. So this is, again, different between inpatient and outpatient. And I think learning how to kind of stratify patients in your mind helps you know what they might need for treatment. So there is this Wesley severity score out there for croup, which is typically what the emergency department, like pediatricians, will be scoring patients when they come in for an acute croup episode. So it goes through all these different factors, like is the patient lethargic, how bad is their noisy breathing, how bad are their other airway symptoms like cyanosis, air entry, retractions, and then you get a number from this. And then when you add up that number, it tells you, do you have mild, moderate, severe, or like really, really severe impending respiratory distress and intubation level. So this is oftentimes like what your EDs are gonna be looking at when kids come in with croup. And then over on the right side, you can see like the management is gonna change depending on which level they fall into. And so that ranges from home management to getting intubated in the ICU, kind of depending on what the numbers are. Every kid, obviously, like taking the whole clinical picture into account is equally as important as like giving them a number on here. But this is just kind of a way in your mind you can start creating a little framework for it. But what about outpatient? Because like I said, the thing that the conundrum that we kind of find more often in ENT practice is what do we do with them outpatient, right? When they come to us and they say, I was just in the hospital for this, you know, what's going on and what do I do? So there's no outpatient scale for croup. The only thing that like we can actually agree on is that if it happens more than 2 times a year, we call it recurrent. I don't know how truly helpful that is for you, but that's pretty much the only thing in the literature that we have. So in my practice, I kind of created this scale for just in seeing different groups of these patients, like how I conceptualize it in my mind. So mild croup is if it's happening 0 to 2 times per year. So some people will come in and they'll be like, oh, they've gotten it, you know, they're 5 and they've had it twice. That would be 0 times per year on average, if they're getting it up to 2 times per year. If there's a clear prodrome, right, if the family's telling you, yeah, every time they get sick with a cold, they're in daycare, they just immediately, like a couple days later, will get that barky cough. So that's the clear viral prodrome that we're talking about. And then no times where they've had to be admitted into the hospital. So this definitely excludes going into the ED, going into urgent care, going into their PCP, because that's going to be almost a universal thing for any kid with croup. But no times where they actually had to be admitted for observation. Versus the severe category are going to be kids that have it more than twice a year, where it comes on really fast. So like the second they get a cold, it immediately turns into croup and they don't have that kind of clear onset. And kids that have been admitted into the hospital, whether that's the ICU or just the floor, like needed some kind of inpatient management more than 1 dose of treatment in the ED. And then you're also gonna get that atypical group where they're not responsive to medical treatments. Maybe they're on a bunch of medications to try to prevent croup and they're still getting it. If any of the symptoms sound kind of weird and not like that classic picture we just talked about. And then kids that are getting hospitalized excessively. So like if a kid is getting admitted to the ICU 3 times a year for croup, that is absolutely not normal in my mind. So that's kind of how I stratify them. And then what do we do? So what are like common treatments for this? So, you know, when a kid is at home calling you, asking you what to do about croup, or when they're in the ED or urgent care, what you're gonna recommend is, you know, just some kind of calming therapies at home. You can do mist. So a lot of times people will say like, oh, you know, take your kid into the bathroom and turn on a steamy shower, or, you know, take them outside into the cool air for a little while to try to calm down some of that hyperreactivity. And then at home, you can also do oral dexamethasone. This is actually often what the first line is when they come into the ED. So I think a lot of times we think they're getting IV as soon as they come in, but the oral dexamethasone is typically the first line. And it's 0.6 mg per kg up to 16 milligrams. And the reason that most people lean towards dexamethasone is because it lasts longer than some of the other steroids. And there's been a lot of papers out there showing its efficacy for this. But if for some reason a kid doesn't tolerate it well and you need to try another steroid, kind of the second most popular one is prednisolone. And then if they're in an inpatient setting where they can be monitored, like in urgent care and ED, you can also do racemic epinephrine, and then obviously you can admit them to the hospital and kind of repeat these therapies. So this is what we all see and do repeatedly for croup, right? We just think croup, treat it with steroids, treat it with rack epi. That's kind of what we do for an acute event. When we see a kid outpatient, these are some of the things I think about, like what can we do to help you? So oral steroids, right? We talked about, like, that's most often what they're getting when they go in. So do you want to give your patient oral steroids to have at home in case they get a croup event? Now, I think that there are some things to think about, right? I kind of gauge how things go with the family during the consultation to see if I think this is a person that is a responsible enough medication steward to give their kids steroids appropriately at home. If I think that's the case, I'm perfectly fine with giving them a couple doses of steroids at home to try to keep them out of the ED and to, save those extra visits. I typically will only prescribe like doses for 2 to 3 croup episodes, because I think if you give unlimited refills, then there's families that are going to be giving their kids steroids, 2 or 3 times a month to try to fend things off. And so I try to do it in a way that, gives them a couple doses, but then if they're using it more than that, they have to call me and I have to kind of gauge how often are you using it and is that an appropriate thing. You can also add in inhaled steroids, which we all have different levels of comfort in prescribing. I personally have super easy access, luckily, to pediatric pulmonology, so typically I will leave it up to them to prescribe it, but I know there's a lot of otolaryngologists out there that will prescribe and manage it, and it can be really helpful for croup, which we'll go a little bit into. And then also, again, if you have access to it where you are, getting some of your subspecialty partners involved in recurrent croup can also be really helpful. So obviously pulmonology is the big one. They're going to be your main partners for managing these kids. But sometimes GI and aerodigestive and allergy and immunology, and we'll talk about why you might want to think about getting those people involved also. And then you also think through, like, well, do I need to do any procedures on this kid, right? Do I need to do an awake scope in clinic? Do I need to do an asleep scope to look at their anatomy, right? A lot of times that's why these kids will make it to you, because they'll see their PCP a bunch of times. The PCP will assume like something's gotta be wrong with their airway, and they'll send them to you to take them to the OR to look. So when you do that, like, what are you looking for? So these are kind of the 3 groups I conceptualize, like, what am I looking for as an otolaryngologist that might be going on in kids with recurrent croup? So obviously the big one is structural problems. So things like subglottic stenosis, subglottic cysts, hemangiomas, all those little weird zebras that we don't see very often, but we know can present with recurrent croup kind of picture. There's also a lot of things out there that can mimic recurrent croup, and I think you can suss a lot of these out with a really good kind of history and physical, but obviously vocal fold dysfunction, tracheomalacia, tracheal stenosis, or complete tracheal rings, especially in like the really little ones that are getting recurrent croup, and then even lower down bronchomalacia can have some of that same like barky cough and stridor and things like that. And then there are all of the inflammatory things that can play a part. And these are things that like we can sometimes gauge when we're down there looking at the airway. But I think without some of those partnerships that we mentioned, we don't get a great assessment for all of these things. But everything in that inflammatory category, like I would argue, is even more common and more important in recurrent croup than any of the structural things that we find. So who needs a bronch? Like I said, a lot of times people will send kids to you for this. And you have to think through, is it worth it for me to put this kid under anesthesia to look down in their airway? Because most of the times when you do that, even if you find something, you're not going to be able to fix it, and you're not going to be able to stop the recurrent croup. So like, what's truly the utility of what you're doing. There have been a lot of articles about this. I think this kind of systematic review is really nice. Basically, they just looked at like what are risk factors for actually having something, and those are a history of intubation, a really young age, like an under 1-year-old should not be getting recurrent croup from an immune perspective. Have they been admitted to the hospital and had an ENT consultation as an inpatient for recurrent croup? And then also another one is history of prematurity. So if you look at this, they have any of those risk factors, then the answer is like, yeah, you're more likely to find something, and you can factor that into your algorithm for if you're gonna take them for a bronch. If they don't have any of these things, oftentimes I'll try to steer families away from it and just, say like, we can go look, but the chance of us finding anything are super low, right? Like under 10%. And even if we do find something, it's probably not gonna change our management. So most of the time, I think you can kind of sway them away from that if you feel like they're not falling into one of these categories where you might find something important to know about. In my mind, the most important one is a history of intubation, because that's something I think like, oh, I might be finding something that I can actually fix. Versus if it's, one of the other ones, even if you're more likely to find something, it's probably gonna be something like grade 1 subglottic stenosis or some tracheomalacia, something that surgically I can't really address while I'm in there. So that's kind of like what we've always done. So now let's talk about some new things that I think you can kind of add into that treatment paradigm that might help you manage these kids a little bit easier. So these are some of the questions that we're gonna talk about, and some of you guys may already be doing some of these things. Depends on how deep you are into the recurrent croup literature, but we're gonna talk about some stuff like, do I need a viral test? Should I be doing those inhaled steroids if I'm not? Do I need to think about a kid swallowing? And then do I need some of those subspecialists involved? And that might, depending on where you practice, might be varying levels of increasing effort on your part to get a kid to them. And then if I'm doing a bronch, is that enough? Do I need to be doing more? And then, what about those like really weird kids that you do everything possible and it doesn't fix them? So first of all, I'm gonna answer each of these questions in a very brief summarized way and then show you some of the literature behind them. So do I need to do a viral test? The answer is probably not. It's not really gonna change anything. Other than if you find something, you can tell the family like, yes, you have parainfluenza and that's what's causing your kid's croup. But how helpful that's gonna be in treating it, not major. So there have been a lot of studies out there looking at different kinds of viruses, especially like in the COVID years, they looked at a bunch of kids that got COVID that turned into recurrent croup. And they basically found that like there's not really any difference in terms of how severe it is, how long it lasts, how you manage it. So doing the actual viral test, not strictly necessary, but a lot of times the urgent care and ED are gonna be getting it anyways. So should I be prescribing inhaled steroids? I would say it depends on your personal comfort, but they're definitely helpful in recurrent croup. And if you're not factoring that into your algorithm, I think that you should be. And so the answer is there's a lot of studies out there that look at does this help? And so, briefly summarizing this paper that really followed a bunch of croup kids that had recurrent croup more than 3 times a year for a period of 1.5 years, which is a reasonable follow-up for kids that are coming in with multiple episodes. I mean, almost 87% of them that were treated with the inhaled steroids had improvement in reducing their croup events, reducing their hospitalizations. And I think that number is high enough for me to say, yeah, it's definitely helpful. And we'll talk in a little bit about like how I dose it and which kids I give intermittent versus scheduled steroids to. Next, does swallowing matter? So the answer is, I think definitely, especially in those refractory cases where like you're treating them with steroids, you're doing all the things, you've given them inhaled steroids and they're still getting croup. Unfortunately, this is anecdotal evidence. There's no great studies out there in the literature. I'm trying to look at some of the kids in our institution so we can get some numbers out there, but there have definitely been multiple kids, especially those weird atypical kids, that you get a swallow study and they're silently aspirating. I think that is a reason why they have a baseline level of airway inflammation and then are so prone to getting that additional level of inflammation as soon as they get sick with a cold. And so in our aerodigestive program that I actually do with Sophia Khan, who just talked about reflux, we actually have a pathway to get those kids into aerodigestive because we think that there's so much overlap in that kind of patient population. What is the utility of getting a pulmonologist involved in early? So I think a lot. I think they're the most important other partner that you can have in a recurrent group, other than the patient's PCP, who also can be helpful to kind of get on the same page as you. But a pulmonologist can help you with a lot of things. So first of all, you have a multidisciplinary partnership who can help you with management of these kids who can be kind of pesky and can have the families calling you all the time, asking for meds, asking for help because they just don't know what to do. So it gives you kind of a shared person who can help manage that, which I think can be helpful. If you're not personally comfortable managing inhaled steroids, they can do it for you. That's like their Augmentin, their Afrin. They give it to literally everyone. So if you're not comfortable managing it and doing education on it, they can also help you with that. And then they can also help you with managing any concurrent pathology, since a lot of times these kids will have an overall reactive picture, right? They'll be ectopic, they'll have asthma. That's something that I don't want to be managing in my practice. So for those kids that are having symptoms even in between their recurrent group, the pulmonologist can really help you out with that. There are procedural adjuncts, so if you're taking the kid to the operating room for a bronchoscopy, they can also join and do a flexible bronchoscopy, see if any chronic infection or inflammation or aspiration is going on that you might be missing, because they can do it with a BAL. And then I think it also gives kids a potential long-term home for management of croup, right? Because as otolaryngologists, a lot of us are gonna say, you know, I'm gonna work you up, I'm gonna have a medication plan, I did a bronchoscopy, I ruled out anything structural, like, I don't know if I need you to be following up in my clinic, you know, every 6 months to check on your croup. You're more than welcome to if you want, but I think it makes a little bit more sense for them to follow long-term with a pulmonologist. I think also, you know, going back to like kids that are having multiple comorbidities is important. So the chances are, if you have recurrent croup as a kid, you're a lot higher likelihood to develop asthma as you continue to get older. And so that's another reason for them to see pulmonology early, because if you look through this paper that looked at 1,200 patients who were seen in the ED for croup, just going down to that data at the bottom. So if you were between 0 and 5 years old when you had your croup, so in that young group, your risk of getting asthma when you're older is 2.13 times more likely, versus if you get croup as an older kid, right, a little bit more into that atypical category, the over 6-year-olds, your risk of getting asthma is 4 times more likely. So that's pretty high compared to the typical kid, and that's another reason that pulmonology can be helpful. So what about GI? Like, why does a GI doctor need to see a kid with recurrent croup, right? And as ENTs, the number one reason is because we love to blame everything on reflux, right? And so they can help you out with that. And sometimes it is reflux. And sometimes it's more that the reflux that's going on, you know, concurrently just isn't making the inflammatory picture any better. But there's also plenty of other GI things that can be going on that can contribute to a recurrent croup picture. So, you know, looking into the reflux kind of thing, the reason I say it's not necessarily causative is because they did this great meta-analysis, like looking at all the papers, and if you look at the little graph over there, you can see like, oh yeah, look at that, like a lot of those patients who were treated with reflux medicine like got better, so that means that a lot of them probably had reflux and that was causing their croup. But if you look at it, like the data is pretty selective. These are only like the most severe kids that end up getting a bronch. There's no control groups. And they didn't really like talk about, you know, the risks of being on long-term reflux management. So I would say it's more something you want to think about managing in those weird kids or kids that are having severe reflux symptoms, but it's not going to be the main thing causing your symptoms in your recurrent croup. Now, what may be causing it is EOE. So there have been a lot of papers coming out recently, and like in the pediatric aerodigestive world, like this is something that we are recognizing is just causes more and more problems, right? So when you summarize all these papers that have come out, EOE is present in 7 to 15% of kids with recurrent croup. So in that group that's getting 2 or more episodes a year, like that is a crazy high number. And like, if they're not seeing GI, like you're missing 15% of the cause of why these kids are having such an inflammatory picture. So I hope that's enough to at least trigger thinking about it sometimes, if that might be something that could be helpful for a kid. Is bronch alone enough? So you think that you need, the kid falls into one of those categories we talked about. You want to take him to the OR to look for anything structural and see what's going on. Like, do you need to do anything other than just a look? I think it depends on your resources, right? Like we talked about, Pullman GI can be really helpful. There's a nice little algorithm showing like which kids should have pulmonary join you and which kids should GI join you. I think in my mind, if a kid is severe enough to be going under anesthesia just for a bronchoscopy, if you have the option of having pulmonology and GI join you to rule out any of those weird things, and it's not like a crazy resource that is a burdensome on the families, like why wouldn't you have that help to get some extra answers? That can either be a primary thing that you utilize or something that, like, if you do a look because you don't have easy access to Pulm and GI, if the kid doesn't get better afterwards, talk to the families about maybe you need to see these people and you might need scopes with them too, right? I think you just have to think through what makes the most sense in your area. What about those weird cases like I talked about? So these are some extra things you can do. So you can think about allergy immunology. Is there an immunologic reason why the kid's getting recurrent croup? And luckily in the pediatric world, a lot of times the allergist is an immunologist, and so they can kind of address both things. There's also some limited papers out there showing that ipratropium nasal spray, interestingly enough, when you take it during an acute episode, can kind of reduce the severity of the recurrent croup, so you can think about that. You can also think about azithromycin, which in pediatric airway reconstruction is an adjunct that we use frequently for kids that just have a refractory inflammatory picture. So like kids that are getting airway surgery, that even though they're on maximum reflux management and inhaled steroids, like they're still having inflammation. You can think about that for recurrent croup. If you're gonna do it, get an EKG first just to make sure they don't have long QT. And then there are some surgeries that have been described out there like that we can do that might help with croup. I've never done one of these for croup because I just don't think that most of the time surgery is the answer. Unless you're going in there and you're finding like the main reason is they have like a higher grade subglottic stenosis. Then you might be able to fix something, but most of the time you're not gonna find something you can easily fix. So to summarize at the end, we're gonna talk about a practical and like pretty simple approach, like this is what I do to manage these kids. So for every patient that comes into my clinic for recurrent croup, you're gonna get a super detailed history, you're gonna quantify and qualify the episodes, and then really try to rule out those mimics that we talked about, which I think most of the time you can do clinically. And then risk stratify them into that mild, severe, or refractory group, because that's gonna change how you treat them. And then obviously talk about comorbidities, make sure you're not missing anything. So for those mild kids that just have mild episodic croup, 0 to 2 times per year, they have that clear prodrome, they're not in the hospital, what are you gonna do? You can give them steroids to have on hand as needed for a croup event to try to keep them out of the hospital. Like this is what they're getting when they go in anyways, so they can have it at home. You can also consider adding the intermittent inhaled corticosteroids at the time of symptoms. So this is a steroid inhaler that they only use at the immediate onset of a cold or croup symptom. So they don't need to use the steroid inhaler all the time, just during croup. You could think about if you want pulmonology to help you out managing these kids. When you get into that severe category, right? So more than 2 times per year, fast onset, hospitalizations, been in the ICU. You do the same steroids on hand as you do for the mild kids, right? Same dosing for the dexamethasone. But in these kids, you're gonna schedule the steroids. So they're gonna take it year round, even when they're not having an acute croup episode. If it helps, eventually you can go down like to using it only during the winter months or just using it as needed, but at first you're just gonna try to get rid of some of that inflammation. So they're gonna do 2 puffs one time a day, and then when they are sick, they're gonna increase that to 2 puffs 2 times a day. You can think about adding in that ipratropium. I think it's pretty benign. You're gonna think about pulmonology. In my case, I would argue if they're getting to this point, I would definitely want pulmonology involved. You're gonna think about aerodigestive. If they have any symptoms that you think are gonna warrant a bronchoscopy. And then for those weird kids, like the atypical ones that like you're doing all that other stuff and they're still having croup episodes, so like they're not responding, they're having excessive hospitalizations, they're using their steroids way too much. So same steroids and inhaled steroid plan as the severe group. Again, consider adding in that nasal spray, consider azithromycin. If you really are reaching, every single one of these kids, even if they have 0 swallowing symptoms, should get a swallow study just to rule out silent aspiration. And they definitely should be seeing both GI and pulmonology, because this is the group that you're saying, like, I need to rule out anything weird. I need to rule out EOE. I need to make sure I'm not missing anything. So in summary, those are the 3 groups, and that's kind of how I treat them every time. And like I said, most kids fall into one of those categories. Obviously, you have to take the whole family and patient into consideration, but hopefully that gives you a little bit of a framework for how you can address these kids and tackle this problem, which can be a little annoying in your own clinic. So happy to answer any questions. Yeah.
What inhaled steroid are you using?
Usually fluticasone, so Flovent, which there are different access problems with that. Like sometimes insurances will approve it and will not approve it. Right now we're in like a good Flovent time in the world, so that's what we order. If you don't have access to that, or if your patient's insurances in your area aren't covering it, I would just ask one of your pulmonologists what their alternative is.
And then how long do you keep these yearly kids? Is it like 1 year and then see how it goes the next year?
Yeah, I usually like if they're really severe, I'll say let's start this. Let's see you back in 4 to 6 months. If it's the mild group, I'll see you back in 1 year. Sometimes we'll continue a yearly follow-up, and then eventually the hope is that they get to a point where they're like not really having it anymore, and at that point I just tell them to come back if they need me. Yeah.
So I find a lot of times these patients show up to us as inpatient consults because this is their second time being admitted, and even though maybe they have like a viral, showing that it's H flu, it's gone on longer than we think it should, and so they're like really asking for a scope. How do you handle those situations?
Yeah, so I never scope these kids when they're in the hospital with croup. I do that for a couple reasons. So first of all, I don't think it's helpful. If you do a flex scope on them, it's going to show subglottic narrowing, and then everyone's going to lose their minds because they think the kid has subglottic stenosis, and like it's not subglottic stenosis. Second of all, if a kid's really severe, like they're teetering on the edge, you do a scope and then they freak out and you've thrown them over the edge into like respiratory distress. And second of all, I don't think it sets like the best precedent for like the pediatricians in terms of what they should expect. Like not every kid with croup needs a bronch or even a flex scope. I think, they're asking for our help. So I think typically what I do is like, I'll see the kid, I'll kind of assess the picture myself. Like, were they admitted because it was really severe? Were they admitted because the parents are so anxious and that, they kind of pushed the admission and don't really need to be there? Or is it a kid with one of those risk factors that I need to say, okay, like let's calm down this croup event, and then, once you're through it, we'll think about going to the OR for a look. So kind of just depends on the picture, but it's a very common inpatient consult. Basically, if they're there for more than a day and not getting better with steroids, they're calling us, so.
I have another question, Claire.
Yeah.
At what point do you do a flex? Would you ever do a flex scope in the office?
Yeah, sometimes I'll do it if the families really want one to like, I'll say like, I'm probably not gonna see exactly what I need to see, but if you don't wanna go to the OR and go under anesthesia, we can do this, and I'll make sure I'm not, missing anything like big, bad, or scary, at least obviously. I also do it for anyone that I'm concerned for vocal cord problems, vocal cord dysfunction, vocal fold immobility, like anything like that, then I'll do it. But it's not a part of my like routine management of them. Did you have a question over here?
So looking at your Aerowiz data to try to strategize, like, is it worth doing a triple scope? Or do you just involve GI in to rule out the EOE, which I do think is a valid component? So when pulmonary does the flex bronchs, how often does it change the treatment management if they're already on the inhaled steroids?
I think the only thing that the pulmonologist sometimes will add, like if they see a lot of inflammation down there or like a chronic infection in the BAL, sometimes they'll treat them for chronic infection. Sometimes they can also get like lab markers that insinuate aspiration. So sometimes if I see that, then I'll order the swallow study, maybe in a kid that I wasn't going to earlier. From a GI perspective, like I love triple scopes. I'm very biased towards them. So like, I feel like if a kid's going to sleep with me, like you're probably gonna get a triple scope because I can just ask my friends to easily come and join. If you don't have access to that easily, I would say like the kids that fall into that like severe category that you're doing everything you can, you're doing steroids, you're doing inhaled steroids, you've ruled out an ENT structural component and they're still having problems, that's when I would send them to GI and say, get an EGD for EOE. And you might need to talk, depending on who your gastroenterologist is and what their level of comfort managing these kids is, you might need to talk to them directly and be like, here's why I'm sending you a kid with airway symptoms that doesn't seem to have any other GI problems because this is what I'm thinking about. Right? Thank you, guys.
All right, everybody, so we have a break until 10:30. Enjoy some refreshments and coffee, and then we'll see you back then.